Welcome to Stroke Rehabilitation, Evidence-Based Update, a comprehensive continuing education course designed for physical therapists, occupational therapists, speech-language pathologists, rehabilitation nurses, and other healthcare professionals involved in stroke rehabilitation. This course will take you on a journey from acute care through community reintegration, synthesizing the latest evidence to help you provide the best possible care for your stroke patients. Stroke remains a leading cause of long-term disability worldwide, affecting approximately 795,000 individuals annually in the United States alone. The complexity of stroke rehabilitation demands that we, as clinicians, integrate knowledge across multiple domains. We must understand acute medical management, neuroplasticity principles, emerging technologies, and health equity considerations to optimize outcomes for each unique patient we encounter. This course synthesizes current evidence from systematic reviews, meta-analyses, and clinical practice guidelines published between 2022 and 2025 to provide you with the knowledge and clinical reasoning skills necessary for evidence-based stroke care across the entire continuum. We have organized this course into 7 modules that progress logically from foundational concepts through advanced topics and practical application. The first 3 modules establish our core framework for stroke rehabilitation, addressing the critical distinctions between acute, subacute, and chronic phase protocols, the patient factors and system characteristics that guide rehabilitation setting selection, and the evidence base for exercise interventions, including aerobic training, resistance exercise, and balance rehabilitation. Module 4 examines the emerging technologies that are reshaping rehabilitation practice, including robotics, virtual reality, transcranial magnetic stimulation, and vagus nerve stimulation. Module 5 addresses the cognitive, psychological, and communication consequences of stroke that significantly impact recovery trajectories and quality of life. Module 6 confronts the implementation barriers and health disparities that limit translation of evidence into equitable clinical practice. Finally, Module 7 integrates concepts from all preceding modules through detailed case studies that illustrate clinical reasoning across diverse stroke presentations. Throughout this course, you will engage with primary literature from peer-reviewed sources, apply evidence to clinical scenarios, and develop the critical appraisal skills necessary for ongoing professional development in this rapidly evolving field. Our case-based approach emphasizes the individualization of evidence-based principles to patient-specific characteristics, preferences, and circumstances, reflecting the reality that optimal stroke rehabilitation requires both scientific knowledge and skilled clinical judgment. Upon completion, you will be prepared to implement current best practices while critically evaluating emerging evidence that will continue to advance stroke rehabilitation science. Let me share with you the learning objectives for this course. Upon successful completion, you will be able to differentiate between acute, subacute, and chronic phase rehabilitation protocols based on timing, intensity, and intervention selection for ischemic and hemorrhagic stroke presentations. You will be able to evaluate patient-specific factors including stroke severity, cognitive status, medical comorbidities, and caregiver support to determine the most appropriate rehabilitation setting for stroke survivors across the recovery continuum. You will learn to compare the effectiveness of exercise-based interventions, including task-specific training, aerobic exercise, resistance training, and balance protocols for optimizing motor recovery at different phases of stroke rehabilitation. Additionally, you will be able to analyze the current evidence for emerging rehabilitation technologies, including robotics, virtual reality, transcranial magnetic stimulation, and vagus nerve stimulation, to identify appropriate candidates and clinical applications. You will learn to interpret cognitive and psychological screening tools for post-stroke depression, anxiety, and vascular cognitive impairment, and identify evidence-based approaches for communication rehabilitation in aphasia. You will analyze implementation barriers to evidence-based stroke rehabilitation across diverse practice settings and identify strategies to promote health equity and rehabilitation access and outcomes. Finally, you will be able to select appropriate outcome measures, rehabilitation interventions, and follow-up intervals based on comprehensive clinical case analysis, integrating concepts from all course modules. Now let us begin with our first module on phase-specific rehabilitation protocols. Stroke rehabilitation represents one of the most complex and time-sensitive domains in neurological recovery, requiring clinicians to navigate critical decisions regarding intervention timing, therapeutic intensity, and protocol selection based on stroke etiology and phase of recovery. The fundamental principle underlying phase-specific rehabilitation is that the brain's capacity for neuroplastic change varies considerably across the recovery continuum, with distinct windows of opportunity that demand tailored therapeutic approaches. Understanding these temporal dynamics enables rehabilitation professionals to optimize functional outcomes while minimizing the risk of secondary complications that can derail the recovery trajectory. The distinction between ischemic and hemorrhagic stroke presentations carries profound implications for rehabilitation timing and intensity decisions. Ischemic strokes account for approximately 87% of all stroke events and generally permit earlier mobilization and more aggressive therapy initiation. In contrast, Hemorrhagic presentations require careful consideration of hematoma stability, intracranial pressure dynamics, and bleeding risk before advancing rehabilitation intensity. These pathophysiological differences necessitate distinct clinical protocols that balance the imperative for early intervention against the risks of premature therapeutic escalation. Contemporary stroke rehabilitation has evolved from a one-size-fits-all approach to a precision medicine paradigm that considers individual patient characteristics, stroke severity, comorbid conditions, and recovery phase when designing intervention protocols. This evolution reflects accumulating evidence that therapeutic timing and dosing interact with underlying neurobiological processes in ways that can either enhance or impede recovery. The challenge for us as clinicians lies in synthesizing this evidence into actionable protocols that can be implemented across diverse practice settings while maintaining fidelity to evidence-based principles. And we must remember that family and caregiver education must begin during the acute phase and continue throughout the recovery continuum, preparing support systems for the challenges of each recovery stage and enabling informed participation in care decisions. The economic and healthcare system implications of phase-specific rehabilitation extend beyond individual patient outcomes to encompass broader questions of resource allocation, care coordination, and value-based healthcare delivery. Early investment in intensive subacute rehabilitation has been associated with reduced long-term disability, decreased need for institutional care, and improved productivity outcomes that generate substantial societal returns on rehabilitation expenditure. However, access to appropriate phase-specific rehabilitation services remains inequitable, with rural populations, racial and ethnic minorities, and uninsured or underinsured individuals experiencing systematic barriers to receiving evidence-based care at the optimal intensity and timing for their recovery phase. Let us now examine the acute phase of stroke rehabilitation, which encompasses the initial period from stroke onset through approximately the first week of hospitalization. During this critical window, medical stabilization and prevention of secondary complications take precedence, while early rehabilitation interventions are carefully initiated. This phase is characterized by heightened neurological vulnerability, evolving stroke pathophysiology, and the need for intensive medical monitoring that shapes the scope and intensity of permissible rehabilitation activities. The Canadian Stroke Best Practice Recommendations emphasize that acute stroke management requires a coordinated interdisciplinary approach that integrates medical management with early rehabilitation assessment and intervention planning. The question of optimal mobilization timing in acute stroke has been the subject of considerable research and clinical debate, with evidence now clarifying that very early mobilization within the first 24 hours may be harmful, while mobilization beginning at 24 to 48 hours post-stroke appears safe and potentially beneficial for most ischemic stroke patients. The landmark AVERT trial and subsequent analyses have demonstrated that high-dose, very early mobilization initiated within 24 hours of stroke onset was associated with reduced odds of favorable outcome at 3 months compared to usual care, fundamentally reshaping clinical practice guidelines regarding mobilization timing. Current evidence supports initiating mobilization for hemodynamically stable ischemic stroke patients between 24 and 48 hours post-onset, with the intensity and duration of early mobility sessions calibrated to individual patient tolerance and neurological status. The rationale for this timing window reflects the balance between avoiding the risks of prolonged immobility, including venous thromboembolism, pneumonia, pressure injuries, and deconditioning, while respecting the brain's need for adequate perfusion during the critical early recovery period. We must assess blood pressure stability, cardiac rhythm, oxygen saturation, and neurological status before each mobilization session, adjusting intervention parameters based on patient response. For hemorrhagic stroke patients, mobilization timing requires additional caution due to concerns regarding hematoma expansion and rebleeding risk during the hyperacute period. Current recommendations suggest delaying mobilization until at least 24 to 48 hours after hemorrhage stabilization has been confirmed through repeat neuroimaging, with some guidelines advocating for more conservative approaches extending to 72 hours or beyond, depending on hemorrhage location, volume, and clinical trajectory. The intensive care management of hemorrhagic stroke patients must balance the competing priorities of maintaining cerebral perfusion pressure, controlling intracranial pressure, and preventing the complications of prolonged bed rest. During the acute phase, rehabilitation interventions focus primarily on positioning, range of motion maintenance, respiratory care, swallowing assessment, and early screening for rehabilitation potential, rather than intensive motor retraining. Proper positioning protocols prevent contracture development, minimize spasticity provocation, and reduce the risk of shoulder subluxation and other musculoskeletal complications that can impede later recovery. Respiratory interventions, including positioning for secretion management, incentive spirometry, and early sitting when medically appropriate, address the elevated pneumonia risk that represents a leading cause of post-stroke mortality. Dysphagia screening must be completed before any oral intake to prevent aspiration pneumonia, with formal swallowing evaluation by speech-language pathology indicated for patients who fail initial screening or demonstrate clinical signs of swallowing dysfunction. The acute phase also involves comprehensive assessment of cognitive function, communication abilities, and psychosocial needs to inform rehabilitation planning and family education. Early involvement of rehabilitation specialists in acute stroke units has been associated with improved outcomes, supporting the model of integrated acute care and rehabilitation services that the American Heart Association standards now recommend. Now let us transition to the subacute phase of rehabilitation, which represents the period of most intensive rehabilitation intervention, typically spanning from approximately 1 week to 3 months post-stroke. During this critical window, the brain demonstrates maximal neuroplastic potential, and patients can tolerate progressive increases in therapy intensity and duration. This phase is often subdivided into early subacute, covering weeks 1 through 4, and late subacute, covering weeks 5 through 12. The early subacute window is considered particularly critical for establishing motor patterns and preventing learned non-use of the affected extremities. The neurobiological rationale for intensive intervention during this period relates to the enhanced synaptic plasticity, neurogenesis, and cortical reorganization that characterize the post-stroke brain during the first several months of recovery. Contemporary evidence strongly supports high-intensity, task-specific rehabilitation during the subacute phase, with guidelines recommending a minimum of 3 hours of daily multidisciplinary therapy for patients receiving inpatient rehabilitation services. The American Heart Association standards for post-acute stroke rehabilitation care emphasize that intensity should be individualized based on patient tolerance and recovery trajectory, but that most stroke survivors benefit from therapy doses substantially higher than those typically provided in routine clinical practice. Research examining dose-response relationships in stroke rehabilitation consistently demonstrates that greater amounts of task-specific practice are associated with larger functional gains, supporting the principle that more therapy generally produces better outcomes during the subacute window. When we examine physical therapy modalities for severe stroke patients, the importance of tailoring intervention intensity to patient capacity while maximizing therapeutic exposure within individual tolerance limits becomes clear. For patients with severe motor impairments who cannot tolerate conventional high-intensity protocols, modified approaches incorporating rest intervals, gravity-eliminated positioning, and assisted movement may enable meaningful participation in rehabilitation activities. The key principle is maintaining the highest feasible intensity while monitoring for signs of excessive fatigue, autonomic instability, or neurological deterioration that would indicate the need for intensity reduction. Task-specific training, which involves repetitive practice of functional activities relevant to the patient's goals and daily life, represents the cornerstone of evidence-based subacute stroke rehabilitation. The neurobiological basis for task specificity relates to the principle that neural circuits are most effectively strengthened through repeated activation in functional contexts, with the brain's plasticity mechanisms responding preferentially to meaningful, goal-directed activities rather than isolated muscle exercises or passive interventions. This approach requires careful analysis of the component skills underlying functional tasks, with training progressing from simpler to more complex task variations as patient competence improves. Upper extremity rehabilitation during the subacute phase emphasizes reaching, grasping, and manipulation activities that address the fine motor control deficits that most significantly impact independence in activities of daily living. For patients with severe upper limb paresis, constraint-induced movement therapy principles may be applied, encouraging use of the affected limb through structured practice protocols while limiting compensatory use of the less affected side. Lower extremity and mobility training focuses on weight-bearing activities, stepping practice, and progressive gait training using body weight support systems when needed to enable safe practice at intensities sufficient to drive motor learning. The integration of aerobic exercise into subacute rehabilitation programs addresses both cardiovascular deconditioning and emerging evidence linking aerobic fitness to enhance neuroplasticity and cognitive recovery. The chronic phase of stroke recovery, conventionally defined as beginning at 3 to 6 months post-stroke, was historically viewed as a period of limited neuroplastic potential during which rehabilitation efforts yielded diminishing returns. Contemporary evidence has fundamentally challenged this perspective, demonstrating that meaningful functional gains remain achievable well into the chronic phase with appropriately designed and sufficiently intensive intervention programs. While spontaneous recovery mechanisms become less prominent in the chronic phase, the brain retains substantial capacity for experience-dependent plasticity that can be harnessed through targeted rehabilitation approaches. This evolving understanding has important implications for rehabilitation service delivery, challenging arbitrary time-based restrictions on therapy access that have historically limited chronic stroke survivors' access to skilled rehabilitation services. The transition from subacute to chronic phase rehabilitation often coincides with discharge from inpatient or intensive outpatient settings to community-based care, creating a critical juncture where continuity of rehabilitation must be maintained despite changes in care setting and intensity. Many stroke survivors experience a significant reduction in therapy access upon transition to the chronic phase, despite ongoing rehabilitation needs and potential for continued improvement. Addressing this care discontinuity requires innovative service delivery models, including telerehabilitation, community-based exercise programs, and self-management support interventions that extend the reach of skilled rehabilitation services into the chronic recovery period. Chronic phase rehabilitation typically emphasizes maintenance of gains achieved during earlier recovery phases, prevention of secondary complications such as contracture and cardiovascular deconditioning, and targeted interventions addressing residual impairments that limit community participation and quality of life. The intensity requirements for achieving functional change in chronic stroke are generally higher than in earlier phases, reflecting the need to overcome established neural patterns and compensatory strategies that may limit access to affected motor systems. Research examining high-intensity interventions in chronic stroke populations has demonstrated clinically meaningful improvements in upper extremity function, gait speed, and balance even years after stroke onset, supporting the value of ongoing access to skilled rehabilitation services. Exercise-based interventions in chronic stroke serve multiple purposes beyond motor skill acquisition, including cardiovascular conditioning, secondary stroke prevention, mood regulation, and maintenance of functional mobility that supports community participation. Clinicians should avoid potentially detrimental medications during the recovery period while implementing evidence-based exercise protocols that address both the neurological and systemic consequences of stroke. Community-based exercise programs, group therapy formats, and home exercise programs with periodic professional supervision represent cost-effective approaches to maintaining rehabilitation gains while addressing the limited access to outpatient rehabilitation services that many chronic stroke survivors experience. Let me now address the differential considerations for ischemic versus hemorrhagic presentations. The pathophysiological distinctions between these two stroke types have important implications for rehabilitation protocol selection that extend beyond the mobilization timing considerations we discussed earlier. Ischemic stroke results from arterial occlusion leading to tissue infarction, with the extent of damage determined by collateral circulation, time to reperfusion, and the volume of salvageable penumbral tissue. The rehabilitation trajectory following ischemic stroke is heavily influenced by reperfusion status, with patients who achieve successful recanalization through thrombolysis or thrombectomy often demonstrating more favorable recovery patterns than those with persistent occlusion. Post-thrombolysis monitoring requirements and hemorrhagic transformation risk must be considered when planning early rehabilitation activities. Hemorrhagic stroke, encompassing both intracerebral hemorrhage and subarachnoid hemorrhage, involves direct tissue destruction and mass effect from the hematoma, secondary injury from perihematomal edema and inflammation, and risks of rebleeding and hydrocephalus that complicate early management. Rehabilitation protocols for hemorrhagic stroke patients must account for the more prolonged period of medical instability, the potential need for surgical intervention or ventricular drainage, and the different timeline of neurological evolution compared to ischemic presentations. Blood pressure management during rehabilitation sessions requires particular attention in hemorrhagic stroke, as excessive elevation during exertion may increase rebleeding risk while overly aggressive blood pressure reduction may compromise cerebral perfusion. Despite these important differences, the fundamental principles of rehabilitation, including early assessment, progressive intensity advancement based on individual tolerance, task-specific training, and comprehensive interdisciplinary care, apply to both stroke types. The Canadian Stroke Best Practice Recommendations provide guidance for managing both ischemic and hemorrhagic presentations within a unified framework that emphasizes individualized care planning and evidence-based intervention selection. Long-term recovery trajectories for hemorrhagic stroke patients are often more favorable than initial severity would predict, reflecting the potential for resolution of mass effect and edema that contributed to acute deficits. This recovery pattern supports ongoing rehabilitation investment in hemorrhagic stroke survivors, even when acute presentations appear severe. The American Heart Association standards for post-acute stroke rehabilitation care provide a comprehensive framework for quality improvement across rehabilitation settings, addressing gaps in stroke program oversight, leadership protocols, and staff education that limit the translation of evidence into practice. National landscape survey data reveal concerning deficits in stroke rehabilitation infrastructure, with 78% of post-acute care sites lacking stroke program oversight structure, 70% lacking stroke rehabilitation leadership, 61% lacking stroke-specific order sets or protocols, and 66% lacking policies requiring staff stroke education. These findings underscore the need for systematic quality improvement efforts to ensure that phase-specific rehabilitation protocols are implemented consistently across the care continuum. Implementation of evidence-based phase-specific protocols requires attention to workforce development, care coordination, outcome monitoring, and continuous quality improvement processes that identify and address barriers to optimal care delivery. Learning collaboratives have demonstrated that most sites can meet proposed quality standards with adequate support and resources, suggesting that infrastructure and education gaps rather than fundamental feasibility concerns underlie current implementation challenges. Those of us working in settings without formal stroke rehabilitation programs can advocate for program development while implementing evidence-based practices within our scope of influence, contributing to incremental improvements in care quality. Systematic outcome monitoring using standardized assessment tools enables clinicians to track recovery trajectories, adjust intervention parameters, and communicate progress across care transitions. The selection of outcome measures should reflect the priorities of each recovery phase, with acute phase assessments emphasizing neurological status and medical stability, subacute assessments focusing on functional gains and therapy response, and chronic phase evaluations addressing community participation and quality of life. The National Institutes of Health Stroke Scale provides a standardized measure of neurological impairment severity that facilitates communication across settings and time points, while functional measures such as the Functional Independence Measure and Barthel Index capture the disability level outcomes most relevant to rehabilitation planning and discharge disposition decisions. Motor recovery assessment during the subacute phase commonly employs the Fugl-Meyer assessment, which provides detailed evaluation of upper and lower extremity motor function using a standardized scoring system that enables tracking of incremental improvements. The minimal clinically important difference for the Fugl-Meyer assessment has been established at approximately 5.25 points for the upper extremity subscale, providing a benchmark for interpreting whether observed changes represent meaningful functional improvement. Gait and mobility assessments, including the 10-meter walk test, 6-minute walk test, and timed up and go, offer reliable measures of locomotor recovery that predict community ambulation capacity and fall risk. Balance assessments such as the Berg Balance Scale provide important prognostic information regarding fall risk and the need for ongoing supervision or assistive device use. The transition from one recovery phase to the next should be guided by objective outcome data rather than arbitrary time-based criteria, with patients demonstrating ongoing functional gains, receiving continued access to intensive rehabilitation services regardless of time since stroke onset. Documentation of outcome trajectories supports clinical decision-making regarding therapy intensity, setting transitions, and intervention modifications while also providing the data necessary for program evaluation and quality improvement initiatives. Now that we have established our understanding of phase-specific rehabilitation protocols, let us move on to examine how we select the most appropriate rehabilitation setting for each patient across the care continuum. The selection of an appropriate rehabilitation setting represents one of the most consequential decisions in post-stroke care, with substantial implications for recovery outcomes, patient and family experience, healthcare resource utilization, and long-term disability trajectories. The contemporary landscape of stroke rehabilitation settings encompasses a spectrum of care environments ranging from intensive inpatient rehabilitation facilities to home-based telerehabilitation programs, each offering distinct advantages and limitations that must be matched to individual patient characteristics and needs. As clinicians engaged in discharge planning and rehabilitation referral decisions, we must navigate complex interactions between patient factors, payer requirements, geographic constraints, and family circumstances to identify the optimal care pathway for each stroke survivor. The timing of rehabilitation setting transitions also carries important implications, as premature discharge from intensive settings may compromise recovery, while prolonged facility-based care beyond the point of maximum benefit increases costs without improving outcomes. The American Heart Association and American Stroke Association policy statement on improving access to stroke rehabilitation and recovery highlights the persistent inequities that limit many stroke survivors' access to appropriate rehabilitation services, particularly affecting underinsured patients, those living in rural areas, and individuals from underrepresented racial and ethnic groups. These disparities reflect not only geographic maldistribution of rehabilitation resources, but also systematic barriers, including prior authorization requirements, restrictive coverage policies, and inadequate recognition of rehabilitation's role in optimizing stroke outcomes. Addressing these barriers requires both policy-level interventions and clinician advocacy to ensure that setting selection decisions are driven by patient need rather than administrative convenience or financial considerations. The evidence base supporting setting-specific rehabilitation outcomes continues to evolve, with emerging research examining the comparative effectiveness of different care models across diverse patient populations and stroke severity levels. While inpatient rehabilitation facilities have traditionally been considered the gold standard for intensive post-acute stroke care, the expanding evidence for alternative settings, including skilled nursing facilities, home health services, and telerehabilitation programs, has broadened the options available to many stroke survivors. The challenge for us lies in matching patients to settings that optimize their recovery potential while respecting patient preferences, family circumstances, and the practical constraints that shape care access in different communities and healthcare systems. Inpatient rehabilitation facilities provide the highest intensity of post-acute stroke rehabilitation services, offering coordinated interdisciplinary care that typically includes a minimum of 3 hours of therapy daily across physical therapy, occupational therapy, and speech-language pathology services, as indicated by patient needs. The intensive service delivery model of inpatient rehabilitation is designed to capitalize on the enhanced neuroplastic potential of the early recovery period, providing the repetitive, task-specific practice necessary to drive motor learning and functional recovery. Patients admitted to inpatient rehabilitation must demonstrate the medical stability and cognitive capacity to participate actively in intensive therapy programs, with Medicare coverage requiring that patients be able to tolerate and benefit from the prescribed therapy intensity. Research examining supplemental gait training approaches in acute stroke inpatient rehabilitation has demonstrated that additional therapy beyond standard care can produce meaningful functional improvements, supporting the dose-response relationship between therapy, intensity, and recovery outcomes. Studies comparing robotic and conventional approaches to supplemental gait training have found that both methods produce functional gains when implemented as additions to standard mandated therapy time. These findings underscore the importance of maximizing therapy exposure during the critical inpatient rehabilitation window, while also suggesting flexibility in the modalities that can achieve therapeutic goals. Appropriate patient selection for inpatient rehabilitation requires systematic evaluation of medical stability, functional status, cognitive capacity, therapy tolerance, and rehabilitation potential. Stroke survivors with moderate to severe functional deficits who demonstrate the ability to participate actively in intensive therapy and have realistic goals for functional improvement represent the ideal candidates for inpatient rehabilitation admission. The presence of multiple comorbidities does not preclude inpatient rehabilitation candidacy, provided that medical conditions can be managed within the rehabilitation environment and do not prevent meaningful participation in therapy programs. Cognitive impairment presents a nuanced consideration, as some degree of cognitive deficit is common after stroke and should not automatically exclude patients from intensive rehabilitation if they can follow instructions and engage in structured therapy activities. Comprehensive cognitive screening using validated instruments such as the Montreal Cognitive Assessment or Mini Mental State Examination provides objective data to inform setting decisions while identifying specific cognitive domains requiring therapeutic attention. The evaluation of rehabilitation potential should consider not only current functional status, but also the trajectory of recovery observed during the acute hospitalization, the presence of prognostic indicators associated with favorable outcomes, and the patient's motivation and engagement with rehabilitation goals. Patients demonstrating rapid early recovery, preserved motor control and affected limbs, absence of severe neglect or anosognosia, and strong social support systems generally have favorable prognoses that support intensive rehabilitation investment. Conversely, patients with severe bilateral deficits, persistent decreased consciousness, profound cognitive impairment limiting therapy participation, or unstable medical conditions may be better served by less intensive settings with enhanced medical monitoring capabilities until their rehabilitation candidacy improves. The prior authorization process for inpatient rehabilitation admission has become a significant barrier to timely care access, with peer-to-peer reviews and appeals processes frequently delaying transfer from acute care settings. These administrative burdens place pressure on acute care hospitals to expedite disposition decisions, sometimes to the detriment of appropriate rehabilitation placement. We must be prepared to advocate effectively for patients who meet medical necessity criteria for inpatient rehabilitation, documenting functional deficits, therapy needs, and anticipated benefits in terms that address payer coverage requirements. Skilled nursing facilities provide an alternative post-acute care setting for stroke survivors who require ongoing medical supervision and rehabilitation services, but may not meet the intensity tolerance criteria for inpatient rehabilitation, or may have other factors favoring a less intensive care environment. The therapy intensity in skilled nursing facilities is typically lower than in inpatient rehabilitation, though substantial variation exists across facilities and patient needs. For some stroke survivors, particularly those with significant medical complexity, advanced age, or limited tolerance for intensive therapy, skilled nursing facilities may represent an appropriate care environment that balances rehabilitation intervention with medical management and supportive care needs. The quality of stroke rehabilitation in skilled nursing facilities varies considerably, with specialized stroke units or rehabilitation-focused facilities generally providing superior outcomes compared to facilities without specific stroke expertise. Patient and family preferences regarding skilled nursing facility placement must be carefully explored, as many individuals express strong preferences to return home rather than receive facility-based care. When skilled nursing facility placement is recommended, transparent discussion of the clinical rationale, expected duration of stay, and anticipated outcomes supports informed decision-making and appropriate expectation setting. Discharge planning from skilled nursing facilities should begin at admission, with clear criteria established for transition to home or other settings and services arranged to support continued recovery after facility discharge. Research examining Medicare Shared Savings Program participation and post-acute care utilization has revealed patterns of institutional post-acute care use that vary by patient population and hospital characteristics. Studies have found that hospital participation in accountable care organizations is associated with different discharge patterns for stroke patients compared to other diagnostic groups, suggesting that financial incentives and care coordination models influence post-acute care placement decisions. These findings highlight the importance of ensuring that value-based payment models do not create perverse incentives that redirect appropriate inpatient rehabilitation candidates to lower-intensity settings for financial rather than clinical reasons. Home-based rehabilitation services, including traditional home health therapy and emerging telerehabilitation models, offer important alternatives for stroke survivors who can safely return to community settings with appropriate support while continuing their rehabilitation programs. Systematic reviews and meta-analyses examining nurse-led telerehabilitation for chronic disease management have found significant improvements in quality of life and self-care outcomes for conditions including stroke, cardiac disease, and diabetes. These findings support the expanding role of telehealth technologies in extending rehabilitation services beyond traditional facility-based settings, particularly for patients facing geographic or transportation barriers to accessing outpatient services. Meta-analyses of telerehabilitation in post-stroke care comparing telerehabilitation to conventional approaches have found modest effects on balance and trunk impairment outcomes. While telerehabilitation may have slightly inferior effects on some activities of daily living measures compared to in-person therapy, the practical advantages of home-based service delivery, including reduced transportation burden, scheduling flexibility, and the ability to practice functional activities in the patient's actual living environment, may offset modest differences in specific outcome measures. The COVID-19 pandemic accelerated adoption of telerehabilitation services, generating valuable experience with remote therapy delivery that continues to inform service development in the post-pandemic era. The feasibility of home-based rehabilitation depends substantially on caregiver availability, home environment accessibility, and family capacity to support the stroke survivor's safety and ongoing rehabilitation activities. Comprehensive discharge planning must assess these factors systematically, identifying needs for home modifications, durable medical equipment, and caregiver training that enable safe and effective home-based care. Stroke survivors returning home require caregivers who can assist with activities of daily living, supervise safety during mobility activities, facilitate home exercise programs, and recognize warning signs requiring medical attention. The demands of caregiving can be substantial, necessitating attention to caregiver well-being and connection to respite and support resources. Home environment assessment should evaluate physical accessibility, including entrance and interior navigation, bathroom safety, and the availability of space for therapy activities and equipment. Environmental modifications such as grab bars, raised toilet seats, shower benches, and ramp installation may be necessary to enable safe home-based care for stroke survivors with mobility limitations. The presence of stairs, the layout of essential living spaces, and proximity to emergency services all influence the appropriateness of home discharge for individual patients. When home environments present significant barriers that cannot be adequately addressed through modification, alternative living arrangements or extended facility-based care may be necessary despite patient and family preferences for home discharge. Outpatient rehabilitation represents the primary modality for continued stroke rehabilitation following discharge from inpatient or facility-based settings, offering structured therapy services that support ongoing recovery while enabling community residents and progressive resumption of life roles. The transition to outpatient rehabilitation typically occurs when patients have achieved sufficient functional independence to manage safely at home with available support, while continuing to demonstrate rehabilitation potential and specific therapy goals that justify ongoing skilled intervention. Outpatient programs vary considerably in structure and intensity, ranging from traditional clinic-based therapy delivered in individual sessions to intensive day rehabilitation programs that approximate inpatient therapy intensity within an outpatient framework. Access to outpatient rehabilitation services represents a significant challenge for many stroke survivors, with transportation barriers, insurance coverage limitations, and geographic distance from rehabilitation providers limiting participation in recommended therapy programs. The frequency and duration of outpatient therapy varies substantially based on patient needs, payer policies, and provider availability, with many stroke survivors receiving less therapy than evidence would suggest optimal for continued recovery. Emerging models of intensive outpatient and day rehabilitation seek to provide higher therapy doses for patients who can benefit from intensive intervention but do not require the continuous supervision and medical monitoring of inpatient settings. These programs may offer particular value during the early community reintegration period when rehabilitation intensity requirements remain high, but residential facility care is no longer necessary. Significant disparities exist in stroke rehabilitation access across racial, ethnic, socioeconomic, and geographic dimensions, with systematic patterns of reduced access to intensive rehabilitation services among marginalized populations. Studies examining racial and rural disparities in stroke discharge disposition have found that among patients who died during hospitalization or within 90 days of discharge, Black and Hispanic patients had significantly lower odds of discharge to hospice or other appropriate settings compared to white patients. Rural residents similarly experienced reduced access to certain post-acute care settings. These disparities reflect the intersection of multiple factors, including insurance coverage differences, geographic distribution of rehabilitation resources, implicit bias in clinical decision-making, and structural barriers within healthcare systems. Addressing rehabilitation access disparities requires multi-level interventions encompassing policy changes, health system reforms, and clinical practice improvements that systematically reduce barriers facing underserved populations. Research priorities should include investigation of interventions specifically designed to improve rehabilitation access for underserved populations, evaluation of alternative service delivery models that can extend rehabilitation reach to underserved areas, and examination of the policy and payment reforms necessary to support equitable rehabilitation access. Rural communities face particular challenges in accessing stroke rehabilitation services due to the concentration of inpatient rehabilitation facilities in urban areas, limited availability of specialized stroke rehabilitation providers, and transportation barriers that impede access to available services. Telerehabilitation offers promise for addressing these geographic disparities, enabling stroke survivors in rural areas to access specialized rehabilitation expertise that would otherwise be unavailable in their communities. However, technology access, internet connectivity, and digital literacy present additional barriers that must be addressed to realize telerehabilitation's potential for reducing rural-urban disparities. Investment in telehealth infrastructure and digital inclusion initiatives represents an important component of strategies to improve rehabilitation equity. Effective rehabilitation setting selection requires integration of multiple patient factors, family circumstances, and system characteristics within a systematic decision-making framework that prioritizes patient outcomes while respecting preferences and practical constraints. The assessment process should begin with comprehensive evaluation of stroke severity, functional deficits, cognitive status, medical complexity, and rehabilitation goals, establishing the baseline from which setting recommendations will be derived. Patient and family preferences must be elicited and incorporated into planning, with education provided regarding the benefits, limitations, and expected outcomes associated with different care options. Patients with moderate to severe functional deficits, adequate cognitive capacity for active therapy participation, medical stability sufficient for intensive rehabilitation, and realistic goals for functional improvement should generally be referred to inpatient rehabilitation facilities when available and accessible. Those with milder deficits, significant medical complexity requiring ongoing nursing care, or limited tolerance for intensive therapy may be better served by skilled nursing facility placement or intensive home health services with close medical follow-up. Telerehabilitation and community-based programs offer important options for patients transitioning from facility-based care or those whose geographic or transportation circumstances limit access to traditional outpatient services. The decision-making process should be documented thoroughly, including the clinical rationale for setting recommendations and the patient and family considerations that influenced final disposition decisions. When preferred settings are not available or accessible due to geographic, financial, or system constraints, the documentation should reflect the barriers encountered and any advocacy efforts undertaken on the patient's behalf. Outcome monitoring following discharge should assess whether patients achieved expected functional gains, experienced complications related to care setting limitations, or required readmission, or setting transitions that might have been prevented through different initial placement decisions. With this foundation in rehabilitation settings established, let us now turn our attention to the exercise-based interventions that form the cornerstone of stroke rehabilitation. Exercise-based interventions form the cornerstone of stroke rehabilitation, with compelling evidence supporting their efficacy in promoting motor recovery, improving cardiovascular fitness, enhancing balance and mobility, and reducing the risk of secondary complications across all phases of recovery. The diversity of exercise modalities available to rehabilitation professionals, ranging from task-specific motor training to high-intensity aerobic protocols, enables individualized intervention programs tailored to patient characteristics, recovery phase, and functional goals. Understanding the relative effectiveness, optimal dosing parameters, and appropriate patient selection criteria for different exercise approaches empowers us to design evidence-based rehabilitation programs that maximize recovery potential while managing the practical constraints of clinical practice. The neurobiological rationale for exercise-based stroke rehabilitation rests on principles of neuroplasticity, the brain's capacity to reorganize neural networks in response to experience and training. Exercise drives neuroplastic change through multiple mechanisms, including enhancement of brain-derived neurotrophic factor and other growth factors, promotion of angiogenesis and improved cerebral blood flow, modulation of neurotransmitter systems, and the experience-dependent strengthening of synaptic connections underlying motor skill acquisition. These mechanisms operate throughout the recovery continuum, though their relative contributions and the intensity thresholds required to engage them may vary across acute, subacute, and chronic phases of recovery. The systematic reviews and meta-analyses examining exercise interventions for stroke rehabilitation have consistently demonstrated clinically meaningful benefits across multiple outcome domains, while also revealing important nuances regarding optimal intervention parameters and patient selection factors. This module synthesizes current evidence to provide practical guidance for implementing exercise-based interventions that align with best available evidence while adapting to the diverse needs and circumstances of individual stroke survivors. The integration of exercise programming with other rehabilitation modalities, including emerging technologies and cognitive behavioral approaches, offers opportunities for synergistic effects that may exceed the benefits of any single intervention approach. Task-specific training represents the most thoroughly validated exercise approach in stroke rehabilitation, with extensive evidence demonstrating that repetitive practice of functional tasks produces superior motor learning outcomes compared to impairment-focused exercises or general strengthening programs. The principle underlying task specificity is that the nervous system adapts most effectively when trained in the context it will be required to perform, creating neural representations that transfer directly to real-world functional demands. Upper extremity task-specific training emphasizes reaching, grasping, and manipulation activities that address the fine motor control and coordination deficits most limiting to independence in activities of daily living, while lower extremity training focuses on weight-bearing, stepping, and gait activities that restore ambulatory function. The dose-response relationship for task-specific training indicates that higher practice volumes generally produce greater functional improvements, supporting the clinical imperative to maximize repetitions of meaningful task practice within and between therapy sessions. Constraint-induced movement therapy represents a structured task-specific approach that combines intensive practice of the affected upper extremity with restraint of the less affected arm to prevent compensatory strategies and promote neural reorganization supporting affected limb function. While the original constraint-induced movement therapy protocol required intensive therapy over consecutive days with extended restraint periods, modified versions providing similar therapeutic principles with more feasible delivery schedules have demonstrated effectiveness in clinical practice settings. Virtual reality-supported exercise therapy has emerged as an innovative approach to stroke rehabilitation that combines the principles of task-specific training with immersive or semi-immersive technological environments designed to enhance engagement, provide augmented feedback, and enable high-repetition practice in motivating contexts. Systematic reviews and meta-analyses examining randomized controlled trials of virtual reality for upper extremity rehabilitation have found significant improvements in motor function as measured by the Fugl-Meyer assessment, with a standardized mean difference of 0.45, along with improvements in range of motion, muscle strength, and independence in daily activities, compared to control conditions receiving either conventional therapy or no therapy. The mechanisms underlying virtual reality's therapeutic benefits appear to involve multiple factors, including increased practice repetitions enabled by engaging game-based formats, enhanced motor learning through augmented visual and auditory feedback, opportunity for error-based learning in safe simulated environments, and the motivational effects of gamification on treatment adherence. Virtual reality systems range from commercially available gaming platforms adapted for rehabilitation use to custom-designed rehabilitation applications with specific therapeutic targets, with evidence supporting benefits across this spectrum of technological sophistication. The accessibility and decreasing cost of consumer virtual reality systems has expanded opportunities for home-based virtual reality exercise programs that extend therapeutic exposure beyond clinical settings. The evidence base for virtual reality exercise therapy demonstrates significant benefits for upper extremity motor function and range of motion, with moderate certainty evidence supporting its use as an adjunct to conventional rehabilitation approaches. Subgroup analyses suggest that outcomes may vary based on patient age, stroke recovery stage, type of virtual reality system employed, and the similarity of intervention duration between virtual reality and control groups. Notably, some evidence indicates that virtual reality benefits may not be maintained after intervention cessation, highlighting the importance of strategies to promote carryover and long-term retention of motor gains. For hand dexterity outcomes, spasticity management, and quality of life measures, the evidence remains more mixed, with significant subgroup differences suggesting that virtual reality effects on these outcomes may be modality-specific or population-dependent. Aerobic exercise interventions address the substantial cardiovascular deconditioning that commonly accompanies stroke, which results from the combined effects of pre-stroke cardiovascular disease, immobility during acute illness, and reduced physical activity during recovery. Bayesian network meta-analyses systematically comparing different aerobic exercise interventions for stroke rehabilitation have examined effects on cardiorespiratory fitness, blood pressure, and mobility outcomes. These comprehensive analyses have found that higher-intensity aerobic exercise protocols, including high-intensity interval training and high-intensity continuous training, demonstrate superior effects on peak oxygen consumption compared to traditional, moderate-intensity approaches, challenging historical preferences for conservative exercise intensity in stroke populations. High-intensity interval training has emerged as the highest-ranked intervention for improving cardiorespiratory fitness in network meta-analyses, with a mean improvement in peak oxygen consumption of 2.9 milliliters per kilogram per minute compared to usual care, supported by moderate certainty evidence. This finding has significant clinical implications, as improved cardiorespiratory fitness correlates with enhanced functional capacity, reduced fatigue, and improved ability to participate in other rehabilitation activities in community life. The feasibility of high-intensity aerobic training for stroke survivors has been established in multiple studies demonstrating acceptable safety profiles when implemented with appropriate screening, monitoring, and progression protocols. Contraindications to high-intensity exercise, including unstable cardiac conditions, uncontrolled hypertension, and certain cerebrovascular pathologies, must be systematically assessed before initiating intensive aerobic programs. Practical implementation of aerobic exercise for stroke survivors requires consideration of exercise modality selection, intensity prescription, progression protocols, and integration with other rehabilitation activities. Treadmill training with bodyweight support, cycle ergometry, aquatic exercise, and recumbent stepping represent commonly utilized modalities that can accommodate varying levels of motor impairment while achieving appropriate cardiovascular training intensities. Exercise intensity may be prescribed using heart rate-based methods, rating of perceived exertion scales, or metabolic equivalents, with individualized prescription accounting for medications that affect heart rate response and any cardiac rhythm abnormalities. The optimal frequency of aerobic training appears to be at least 3 sessions per week, with session durations progressing from 20 to 60 minutes as tolerance develops. Integration of aerobic exercise with motor skill training presents both opportunities and challenges, as the timing of aerobic activity relative to motor practice may influence learning and retention outcomes. Emerging evidence suggests that aerobic exercise performed before or concurrently with motor practice may prime neuroplastic mechanisms that enhance motor learning, though optimal protocols for capitalizing on these effects remain under investigation. The association between aerobic fitness and cognitive function in stroke populations provides additional rationale for prioritizing cardiovascular conditioning as a component of comprehensive stroke rehabilitation, with potential benefits extending beyond physical fitness to encompass attention, processing speed, and executive function domains important for rehabilitation participation and community reintegration. Resistance training addresses the muscle weakness and reduced force production capacity that commonly limit functional performance in stroke survivors, with evidence supporting significant benefits for strength, functional mobility, and activities of daily living outcomes. Randomized controlled trials comparing low-intensity resistance training with blood flow restriction to traditional high-intensity resistance training in ischemic stroke survivors have demonstrated that both approaches produce significant improvements in lower extremity, muscle strength, balance, walking capacity, and psychological outcomes. Notably, the blood flow restriction approach achieves comparable benefits at substantially lower loading intensities, offering an alternative for patients who cannot tolerate high-load resistance training due to joint pathology, pain, or other limiting factors. The physiological rationale for blood flow restriction training relates to the metabolic stress and hypoxic conditions created by partial vascular occlusion during low-load exercise, which stimulate muscle protein synthesis and hypertrophic adaptations, similar to those achieved with high-load training. For stroke survivors with limited ability to perform high-intensity exercise, blood flow restriction training may provide a mechanism for achieving meaningful strength gains while reducing joint stress and cardiovascular demands. The technique requires appropriate training for safe implementation, including proper cuff selection and inflation protocols, patient monitoring, and recognition of contraindications including peripheral vascular disease, venous thrombosis history, and certain cardiovascular conditions. Traditional progressive resistance training for stroke rehabilitation follows principles of overload and progression established in exercise physiology, with resistance levels initially set at manageable intensities and systematically increased as strength improves. The optimal training parameters for stroke populations appear similar to those recommended for healthy adults, including 2 to 3 sessions per week, multiple sets of exercises targeting major muscle groups, and progression to higher resistance levels as performance improves. However, adaptations may be necessary to accommodate motor control deficits, spasticity, and sensory impairments that complicate traditional resistance training execution in stroke populations. Exercise selection for resistance training should target muscle groups most relevant to functional performance while considering the impact of weakness distribution patterns common after stroke. The hemiplegic pattern of weakness, with greater involvement of distal and anti-gravity muscles, guides prioritization of exercises addressing hand and wrist function, knee and ankle control, and hip strength that supports standing and ambulation. Bilateral exercises may enable higher training volumes by allowing the less affected limb to assist, while unilateral exercises more directly target affected limb strength gains. Equipment adaptations, including modified grip handles, positioning supports, and weight systems that accommodate limited range of motion, enable meaningful resistance training participation for patients with significant motor impairments. The safety of resistance training for stroke survivors has been established through multiple studies, demonstrating acceptable cardiovascular responses and absence of adverse neurological effects when appropriate screening and monitoring protocols are implemented. Blood pressure responses during resistance exercise can be substantial, necessitating attention to blood pressure management and avoidance of Valsalva maneuvers that cause acute pressure elevations. Patients with poorly controlled hypertension, recent cardiac events, or certain cerebrovascular pathologies may require modified protocols or medical clearance before initiating progressive resistance training. Balance impairment represents a primary factor limiting mobility and community participation in stroke survivors, with the associated fall risk contributing substantially to post-stroke morbidity and healthcare utilization. Systematic reviews and meta-analyses examining vestibular rehabilitation and dual-task training for stroke survivors have found significant benefits for balance outcomes, with standardized mean differences indicating large effect sizes for balance-specific training approaches. Vestibular rehabilitation, which targets the vestibular contributions to postural control through habituation, gaze stabilization, and balance exercises, demonstrates particular promise despite limited integration into current stroke rehabilitation guidelines. Dual-task training, which involves simultaneous performance of motor and cognitive tasks, addresses the attentional demands that commonly compromise gait and balance in stroke survivors when walking in complex real-world environments. Meta-analysis findings suggest moderate beneficial effects of dual-task training on gait outcomes, with particular value when compared to single-task training approaches that may not adequately prepare patients for the multitasking demands of community ambulation. An optimal comprehensive program for late subacute and chronic stroke populations should incorporate balance-specific training with components addressing gait and strength, reflecting the multifactorial nature of postural control and fall risk in this population. Water-based exercise therapy offers unique advantages for balance and gait rehabilitation in stroke populations, with the buoyancy of water providing partial weight support that enables earlier weight-bearing exercise while reducing fall risk during balance challenges. Randomized controlled trials examining aquatic exercise for lower limb rehabilitation in hemiplegic stroke patients have demonstrated significant improvements in balance as measured by the Berg Balance Scale, walking function as measured by the functional ambulation category, limb motor function, and daily living abilities compared to conventional land-based therapy. The supportive properties of water combined with its resistance characteristics enable therapeutic exercise at functional intensities that may not be achievable in land-based settings for patients with significant motor impairments. Fall prevention represents a critical outcome of balance training programs, as falls represent a leading cause of injury and healthcare utilization in stroke survivors, with fall rates substantially elevated compared to age-matched individuals without stroke history. Comprehensive fall prevention programs address multiple contributing factors including balance impairment, lower extremity weakness, sensory deficits, medication effects, environmental hazards, and cognitive factors affecting safety awareness and judgment. Perturbation-based balance training, which involves exposure to unexpected balance disturbances in controlled therapeutic environments, has shown particular promise for reducing fall rates by training reactive balance responses that protect against unexpected challenges encountered in daily activities. The integration of balance training with environmental modification, assistive device prescription, and patient and caregiver education creates comprehensive fall prevention approaches that address the multifactorial nature of fall risk in stroke populations. Home safety assessments identify environmental hazards and inform recommendations for modifications that reduce fall risk in the patient's actual living environment. Proper prescription and training in the use of assistive devices, including canes, walkers, and wheelchairs, enables safe mobility at the appropriate level of independence while providing backup support when balance is challenged beyond the patient's reactive capacity. The effectiveness of exercise-based stroke rehabilitation depends substantially on the application of motor learning principles that optimize the translation of practice into lasting motor skill acquisition. Research examining the role of the contralesional motor cortex in upper limb recovery highlights the complex neural dynamics underlying motor rehabilitation, with implications for understanding how exercise interventions influence interhemispheric balance and motor cortex reorganization. Task-specific training approaches that engage both hemispheres through bilateral activities or targeted unilateral practice may optimize neuroplastic outcomes by leveraging the compensatory and facilitatory roles of intact cortical regions. Key motor learning principles applicable to exercise prescription include the importance of practice specificity, the benefits of variable practice for skill generalization, the role of feedback timing and frequency in learning optimization, and the impact of practice distribution on skill retention. Exercise programs should incorporate these principles by emphasizing functional task practice that closely resembles real-world activities, introducing appropriate variability to promote flexible motor control, providing feedback that guides performance improvement without creating dependency, and scheduling practice sessions to optimize learning consolidation processes. The integration of these principles with adequate practice intensity and appropriate challenge levels creates conditions that maximize the neural adaptations underlying motor recovery. Effective implementation of exercise-based interventions requires systematic assessment of patient characteristics, goal-setting processes that engage patients and families in rehabilitation planning, and program design that addresses individual needs within the practical constraints of clinical settings and available resources. Initial assessment should characterize motor impairments across affected body regions, evaluate cardiovascular fitness and exercise tolerance, assess balance and fall risk, and identify cognitive and behavioral factors that influence exercise, participation, and learning capacity. Standardized assessment tools enable objective documentation of baseline status and tracking of progress throughout the rehabilitation course. Goal setting should follow principles of patient-centered care, with goals reflecting patient priorities and meaningful functional outcomes rather than solely impairment-level targets. The SMART goal framework, emphasizing specific, measurable, achievable, relevant, and time-bound objectives, provides structure for goal development while the integration of patient perspectives ensures that rehabilitation efforts address the activities and roles most important to individual stroke survivors. Regular goal review enables adjustment based on progress and changing priorities, maintaining alignment between rehabilitation activities and meaningful outcomes throughout the recovery course. Program design should integrate multiple exercise modalities to address the diverse impairments and functional limitations present in most stroke survivors, rather than focusing exclusively on any single intervention approach. A comprehensive program might combine task-specific upper extremity training, aerobic exercise, progressive resistance training, and balance activities within a structured schedule that allows adequate volume of each modality while avoiding excessive fatigue that could compromise motor learning. The sequencing and timing of different exercise components within and across sessions may influence outcomes, with emerging evidence suggesting that aerobic exercise may prime neuroplastic mechanisms when performed before motor skill practice. Having established our understanding of exercise-based interventions, let us now explore the emerging technologies that are expanding our therapeutic toolkit in stroke rehabilitation. The landscape of stroke rehabilitation has been transformed by technological innovations that offer new mechanisms for delivering therapeutic interventions, augmenting neuroplastic processes, and extending rehabilitation access beyond traditional clinical settings. Emerging technologies including robotic therapy systems, immersive virtual reality environments, and neuromodulation techniques such as transcranial magnetic stimulation and vagus nerve stimulation represent some of the most actively researched areas in contemporary stroke rehabilitation science. While these technologies hold substantial promise for improving outcomes, their appropriate integration into clinical practice requires careful consideration of the evidence base, patient selection criteria, implementation requirements, and cost-effectiveness relative to conventional approaches. The rationale for technology-augmented rehabilitation rests on several potential advantages over conventional therapy alone, including the capacity to deliver high-repetition training with consistent quality, provide precise quantitative feedback on performance, enable training at intensities or in conditions not achievable through manual therapy, and potentially enhance neuroplasticity through direct modulation of neural activity. However, technological sophistication does not automatically translate to clinical superiority, and the evidence base for different technologies varies considerably in quality and consistency. We must develop the capacity to critically evaluate technology claims, identify patients most likely to benefit from specific technological approaches, and integrate technology appropriately within comprehensive rehabilitation programs. In this module, we will examine 4 categories of emerging rehabilitation technology: robotic therapy systems for upper and lower extremity rehabilitation, virtual reality applications across multiple functional domains, transcranial magnetic stimulation and other non-invasive brain stimulation approaches, and vagus nerve stimulation as an emerging neuromodulation strategy. For each technology category, we will consider the underlying mechanisms, evidence for effectiveness, patient selection considerations, and practical implementation factors that inform clinical decision-making. The goal is to equip you with the knowledge necessary to make evidence-informed decisions about technology integration in your clinical practice. Robotic rehabilitation systems have evolved substantially since their introduction to stroke rehabilitation, with current devices offering sophisticated capabilities for upper and lower extremity training across a range of impairment severities and functional goals. Meta-analyses examining portable robots for post-stroke upper limb rehabilitation have synthesized evidence from randomized controlled trials comparing robotic-assisted therapy to conventional approaches, finding significant benefits for motor function as measured by the Fugl-Meyer assessment, upper extremity subscale, with a standardized mean difference of 0.69, as well as improvements on the Action Research Arm test. These findings support the effectiveness of robotic therapy for upper extremity motor recovery, while also revealing important nuances regarding optimal dosing, timing, and patient characteristics that moderate treatment effects. The mechanisms underlying robotic therapy benefits involve multiple factors, including the capacity to deliver high repetition, task-specific training with consistent movement quality, provision of assistance that enables practice at functional levels beyond unassisted capability, and real-time feedback that supports motor learning and patient engagement. Different robotic systems offer varying degrees of assistance, from fully assistive devices that guide passive movement through active assistive systems that provide support only as needed to resistive systems that challenge patients to work against the device. The assist-as-needed paradigm, which automatically adjusts assistance levels based on patient performance, represents a particularly promising approach for optimizing the therapeutic challenge level throughout the training session and across the recovery trajectory. Upper extremity robotic systems range from end-effector devices that interact with the patient at a single distal point to exoskeleton designs that control movement at multiple joints throughout the arm. End-effector robots typically guide hand or wrist movement through reaching or manipulation tasks, providing a more naturalistic training experience, but less precise control over individual joint motions. Exoskeleton robots offer greater biomechanical control and the ability to target specific joint movements, potentially enabling more precise therapeutic targeting, but often at the cost of increased setup complexity and reduced movement naturalness. The choice between device types should consider patient characteristics, therapeutic goals, and practical factors including device availability, setup time, and clinician expertise. Portable robot systems offer particular promise for expanding access to robotic rehabilitation beyond specialized centers, with devices designed for home-based or community clinic use, potentially enabling sustained high-intensity training throughout the subacute and chronic recovery phases. Home-based robotic therapy addresses significant barriers to rehabilitation access, including transportation challenges, limited outpatient therapy availability, and the need for ongoing intervention beyond the typical duration of facility-based services. However, remote supervision requirements, patient selection for safe, independent use, and the need for technical support present implementation challenges that must be addressed for successful home-based robotic programs. Robotic systems for lower extremity rehabilitation include treadmill-based gait training devices, overground exoskeletons, and stationary systems targeting specific aspects of lower limb function such as ankle movement or weight shifting. The Cochrane Systematic Review examining electromechanical assisted gait training, which included 62 randomized controlled trials with 2,440 participants, provides high-quality evidence that robotic gait training in combination with physiotherapy significantly increases the odds of achieving independent ambulation, with an odds ratio of 2.01 and a 95% confidence interval of 1.51 to 2.69. The number needed to treat is 8 patients. Post-hoc analyses indicated that patients who are non-ambulatory within the first 3 months post-stroke derive the greatest benefit from this intervention. Treadmill-based systems with bodyweight support enable repetitive gait practice at volumes that may exceed what is achievable through conventional overground training, while the consistency of robotic guidance ensures appropriate movement patterns throughout extended training sessions. Patient selection for robotic gait training should consider the level of motor impairment, with evidence suggesting particular benefit for patients with more severe gait deficits who cannot achieve sufficient practice volume through conventional approaches. For patients with milder impairments who can walk independently or with minimal assistance, intensive conventional gait training may be equally effective and more readily available than robotic approaches. The combination of robotic gait training with other interventions, including functional electrical stimulation, virtual reality feedback, and brain stimulation, represents an active area of investigation seeking to maximize the benefits of technology-augmented rehabilitation. Virtual reality technology has emerged as a versatile platform for stroke rehabilitation, with applications spanning motor training, cognitive rehabilitation, balance and gait intervention, and activities of daily living practice in simulated functional environments. The Cochrane Systematic Review, updated through 2024, provides the most comprehensive synthesis of virtual reality evidence in stroke rehabilitation, finding that virtual reality probably increases upper limb function when added to usual care, with a standardized mean difference of 0.42 and moderate certainty evidence, as well as activities of daily living when used as an adjunct to usual care. The review also identified benefits for balance and gait outcomes, while noting important limitations in the evidence base, including small sample sizes, heterogeneous intervention protocols, and limited long-term follow-up. The therapeutic mechanisms of virtual reality relate to its capacity to create engaging, motivating environments that promote high-repetition practice, provide augmented sensory feedback that enhances motor learning, and enable task practice in simulated functional contexts that may transfer to real-world performance. Immersive virtual reality systems using head-mounted displays create compelling sensory environments that may enhance presence and engagement, while non-immersive systems using standard displays offer simpler implementation with reduced equipment costs and lower risk of cybersickness. The choice between immersive and non-immersive approaches should consider patient tolerance, therapeutic goals, and practical implementation factors. Successful clinical implementation of virtual reality rehabilitation requires attention to equipment selection, patient assessment and training, session structure, and integration with comprehensive rehabilitation programs. Equipment options range from consumer gaming systems adapted for rehabilitation use to purpose-built rehabilitation virtual reality systems with specific therapeutic applications and outcome tracking capabilities. Consumer systems offer cost advantages and familiar interfaces but may lack the therapeutic specificity and clinical data management features of dedicated rehabilitation platforms. The selection should balance cost considerations against therapeutic requirements and the clinical setting's technical support capabilities. Patient assessment for virtual reality suitability should evaluate visual function, vestibular status, cognitive capacity to engage with virtual environments, and any history of motion sensitivity or seizure disorders that might be exacerbated by virtual reality exposure. Gradual introduction with shorter initial sessions and progressive increase in duration and immersion level enables identification of patients who experience adverse effects while building tolerance in those with initial sensitivity. Session structure should incorporate rest breaks, varied activities to maintain engagement, and integration of virtual reality training with other therapeutic activities that address goals not amenable to virtual reality intervention. Non-invasive brain stimulation techniques, including transcranial magnetic stimulation and transcranial direct current stimulation, represent a fundamentally different approach to rehabilitation technology, directly modulating neural activity to enhance the brain's capacity for plasticity and motor learning. Meta-analyses examining transcranial magnetic stimulation effects on cortical excitability and motor function in stroke patients have found significant modulation of cortical excitability measures and improvements in motor function outcomes, though with considerable heterogeneity across studies reflecting differences in stimulation parameters, patient populations, and concurrent therapies. The theoretical basis for brain stimulation in stroke rehabilitation relates to the interhemispheric imbalance model, in which excessive inhibition from the contralesional hemisphere suppresses activity in paralesional motor regions, limiting functional recovery. Network meta-analyses comparing different non-invasive brain stimulation modalities provide valuable guidance for understanding the relative effectiveness of various approaches, finding that transcranial auricular vagus nerve stimulation ranked highest for motor function improvement among the stimulation techniques examined, with a standardized mean difference of 1.20. This finding highlights the potential of vagal stimulation approaches while also demonstrating meaningful benefits for transcranial magnetic stimulation and transcranial direct current stimulation protocols. The optimal stimulation parameters, including frequency, intensity, duration, and timing relative to motor training, remain areas of active investigation with substantial variability across published protocols. Transcranial magnetic stimulation protocols for stroke rehabilitation typically employ either excitatory stimulation, targeting the lesioned hemisphere to enhance paralesional activity, or inhibitory stimulation of the contralesional hemisphere to reduce interhemispheric inhibition, with some protocols combining both approaches. Repetitive transcranial magnetic stimulation using high-frequency protocols, typically 5 to 20 Hz, over the ipsilesional motor cortex aims to increase cortical excitability and enhance the response to subsequent motor training, while low-frequency stimulation, typically 1 Hz, over the contralesional motor cortex reduces inhibitory influences on the damaged hemisphere. Theta burst stimulation protocols offer an alternative approach with shorter session durations that may improve clinical feasibility while achieving similar modulatory effects. Patient selection for transcranial magnetic stimulation should consider stroke location and extent, time since stroke, presence of motor evoked potentials indicating corticospinal tract integrity, and contraindications including seizure history, implanted devices, and certain medications that affect seizure threshold. The combination of brain stimulation with motor training appears essential for translating stimulation-induced plasticity into functional improvement, with stimulation serving to prime neural circuits for subsequent experience-dependent strengthening through practice. Implementation requires specialized equipment, trained personnel, and appropriate safety protocols, limiting current availability primarily to academic medical centers and specialized rehabilitation facilities. Vagus nerve stimulation represents an emerging neuromodulation approach for stroke rehabilitation that has progressed from investigational status to clinical application based on promising randomized controlled trial results. Comprehensive reviews examining the evidence for vagus nerve stimulation in ischemic stroke recovery describe both the underlying mechanisms and clinical trial outcomes that support its therapeutic potential. The rationale for vagus nerve stimulation in stroke rehabilitation relates to its effects on neuromodulatory systems, particularly the release of norepinephrine and acetylcholine that enhance synaptic plasticity, combined with anti-inflammatory effects that may support recovery in the post-stroke brain. Vagus nerve stimulation can be delivered through surgically implanted devices that directly stimulate the cervical vagus nerve or through non-invasive transcutaneous approaches targeting the auricular branch of the vagus nerve accessible at the ear. The implanted approach, which has received FDA clearance for stroke rehabilitation, involves pairing brief stimulation pulses with specific movements during rehabilitation exercises, with the stimulation serving to reinforce the neural circuits activated by movement practice. This paired stimulation paradigm differs from continuous stimulation approaches used in other vagus nerve stimulation applications, with the temporal coupling of stimulation and movement considered essential for the rehabilitative effect. The pivotal randomized controlled trials of paired vagus nerve stimulation for upper extremity stroke rehabilitation have demonstrated clinically meaningful improvements in arm function compared to rehabilitation alone, leading to regulatory approval and initial clinical implementation. The VNS Rehab trial showed significantly greater improvement in Fugl-Meyer assessment scores and functional measures in patients receiving active stimulation paired with intensive rehabilitation compared to those receiving rehabilitation with sham stimulation. Long-term follow-up data suggests the benefits are maintained beyond the active treatment period, potentially reflecting lasting neural reorganization induced by the intervention. Patient selection for implanted vagus nerve stimulation currently focuses on chronic stroke survivors with moderate upper extremity impairment who have not achieved satisfactory recovery with conventional rehabilitation, reflecting the trial populations in which efficacy has been demonstrated. The surgical implantation procedure carries typical surgical risks and device-related considerations, including battery replacement requirements over time. Non-invasive transcutaneous auricular vagus nerve stimulation offers a lower-risk alternative that has shown promising results in preliminary studies and may expand access to vagal neuromodulation for stroke rehabilitation as the evidence base develops. The ranking of transcutaneous auricular vagus nerve stimulation as the most effective brain stimulation modality in network meta-analyses supports continued investigation of this accessible approach. The optimal approach to technology integration in stroke rehabilitation likely involves strategic combination of multiple technologies with conventional therapy rather than reliance on any single technological solution. Emerging evidence supports combinations such as robotic therapy with virtual reality feedback, brain stimulation priming followed by intensive motor training, and multimodal protocols that leverage the distinct mechanisms of different technologies. The development of clinical decision frameworks for technology selection based on patient characteristics, recovery phase, and functional goals represents an important priority for translating the expanding technology evidence base into routine clinical practice. Future directions in rehabilitation technology include advances in brain-computer interfaces that enable direct neural control of assistive devices, artificial intelligence systems that personalize rehabilitation protocols based on individual response patterns, wearable sensors that enable continuous monitoring of rehabilitation activity and outcomes in community settings, and closed-loop systems that automatically adjust intervention parameters based on real-time physiological feedback. These developments promise increasingly sophisticated and personalized rehabilitation interventions while also raising important questions about access, equity, and the appropriate balance between technological and human elements in rehabilitation care. Now that we have explored these emerging technologies, let us turn our attention to the cognitive, psychological, and communication consequences of stroke that significantly impact rehabilitation participation and recovery. Stroke affects far more than motor function, with cognitive impairment, psychological disturbances, and communication disorders representing common consequences that significantly impact rehabilitation participation, functional outcomes, and quality of life. Vascular cognitive impairment affects up to 60% of stroke survivors, with deficits spanning attention, memory, executive function, and processing speed domains that interfere with learning, problem-solving, and independent daily functioning. Post-stroke depression affects approximately one-third of stroke survivors and is associated with poorer rehabilitation outcomes, increased mortality, and reduced quality of life for both patients and caregivers alike. Aphasia, the acquired language disorder resulting from damage to language-dominant hemisphere regions, affects approximately 30% of acute stroke patients and presents profound challenges for communication, social participation, and psychological well-being. The interconnections among cognitive, psychological, and communication domains create complex clinical presentations that require integrated assessment and intervention approaches. Cognitive impairment may contribute to depression through awareness of functional losses, while depression itself impairs cognitive performance through effects on attention, motivation, and processing speed. Language impairment limits the individual's ability to express emotional distress, potentially leading to underrecognition of psychological disorders in aphasic patients. Effective rehabilitation must address these interrelated domains systematically, with screening protocols that identify impairments across all relevant areas and intervention programs that recognize and address the connections among them. The Canadian Stroke Best Practice Recommendations on Vascular Cognitive Impairment provide comprehensive guidance for the assessment and management of cognitive dysfunction following stroke and other cerebrovascular conditions. These recommendations emphasize that all patients with stroke or transient ischemic attack should be screened for cognitive impairment using validated screening tools with comprehensive neuropsychological assessment, indicated for patients with positive screening results or functional concerns that suggest cognitive deficits requiring detailed characterization. The Montreal Cognitive Assessment represents the most widely recommended screening instrument, with its sensitivity to executive dysfunction and processing speed deficits making it particularly appropriate for detecting the cognitive profile most commonly associated with cerebrovascular disease. The cognitive profile of vascular cognitive impairment typically differs from that of Alzheimer's disease, with relatively greater impairment in attention, executive function, and processing speed compared to the memory-predominant pattern characteristic of Alzheimer's pathology. However, mixed pathology combining vascular and neurodegenerative contributions is common, particularly in older stroke survivors, creating heterogeneous cognitive presentations that may evolve over time. Longitudinal cognitive monitoring enables detection of progressive decline that might indicate evolving dementia, while also identifying patterns of recovery or stability that inform rehabilitation planning and patient counseling. Cognitive rehabilitation for vascular cognitive impairment encompasses both restorative approaches that aim to improve underlying cognitive capacity and compensatory strategies that enable functional performance despite persistent deficits. Restorative interventions typically involve structured practice of cognitive tasks targeting impaired domains, based on the principle that repeated activation of neural circuits supports neuroplastic strengthening, similar to motor rehabilitation. Attention process training, memory strategy instruction, and executive function interventions have demonstrated benefits in research settings, though translation to functional outcomes remains variable. Compensatory approaches focus on external aids, environmental modifications, and behavioral strategies that enable task completion without requiring improved underlying cognitive capacity. Specific cognitive rehabilitation techniques include attention training programs that progress from simple sustained attention tasks through selective and divided attention challenges, memory training incorporating encoding strategies, spaced retrieval practice, and errorless learning approaches that prevent consolidation of incorrect responses. Executive function rehabilitation addresses planning, organization, problem-solving, and self-monitoring through structured practice of complex tasks, combined with metacognitive training that builds awareness of cognitive processes and strategy use. Computer-based cognitive training programs offer opportunities for intensive, standardized practice with automatic difficulty adjustment, though the transfer of gains from computerized tasks to functional performance remains an area requiring further investigation. The integration of cognitive rehabilitation with motor and functional training reflects growing recognition that cognitive demands are embedded throughout daily activities and rehabilitation tasks. Dual-task training approaches that combine motor practice with concurrent cognitive demands may better prepare patients for the cognitive complexity of real-world functional activities than isolated motor or cognitive training. The modification of motor rehabilitation approaches to accommodate cognitive limitations, such as simplified instructions, external cueing, and environmental structuring, enables meaningful participation in motor rehabilitation for patients whose cognitive impairments would otherwise limit engagement with conventional approaches. Post-stroke depression represents one of the most common and consequential complications of stroke, affecting approximately 30% of survivors within the first year and associated with poorer functional outcomes, increased mortality, and substantial reduction in quality of life for patients and caregivers alike. Network meta-analyses examining non-pharmacological interventions for post-stroke depression provide valuable guidance for understanding the relative effectiveness of different therapeutic approaches, finding that home-based exercise interventions demonstrated the highest efficacy for reducing depressive symptoms among the interventions examined. This finding has important implications for rehabilitation practice, suggesting that exercise programs designed for home implementation may provide dual benefits for physical recovery and psychological well-being. Screening for post-stroke depression should be implemented routinely using validated instruments appropriate for stroke populations, with attention to the potential impact of aphasia and cognitive impairment on screening accuracy. The Patient Health Questionnaire 9 and the Hospital Anxiety and Depression Scale represent commonly used screening instruments, though modified approaches may be necessary for patients with significant communication impairments. Visual analog scales, observational rating instruments, and aphasia-friendly assessment tools enable depression screening in patients whose language deficits preclude standard self-report measures. The persistence of depressive symptoms despite optimization of rehabilitation and medical management should prompt referral for specialized psychiatric or psychological evaluation and treatment. The evidence base for post-stroke depression treatment encompasses both pharmacological and non-pharmacological approaches, with integrated treatment programs often combining multiple modalities. Antidepressant medications, particularly selective serotonin reuptake inhibitors, have demonstrated efficacy for post-stroke depression in multiple trials, though concerns regarding side effects, drug interactions, and potential effects on stroke recovery warrant careful consideration in treatment selection. Network meta-analysis findings ranking home-based exercise as the most effective non-pharmacological intervention provide support for exercise-based approaches that address both mood and physical function, potentially offering advantages over pharmacological treatment for patients concerned about medication side effects or those with contraindications to antidepressant use. Psychological interventions, including cognitive behavioral therapy, problem-solving therapy, and motivational interviewing, have shown promise for post-stroke depression, though the evidence base remains more limited than for pharmacological treatment. Adaptation of psychological therapies for stroke populations may require modifications to accommodate cognitive and communication impairments, such as simplified content repetition, written materials, and involvement of family members in treatment sessions. Group-based interventions offer potential benefits through peer support and social connection, addressing the isolation that commonly accompanies post-stroke disability while providing cost-effective delivery of psychological intervention content. Behavioral activation, a core component of cognitive behavioral approaches, focuses on increasing engagement in meaningful and pleasurable activities as a pathway to mood improvement. For stroke survivors, behavioral activation must be adapted to accommodate physical limitations while identifying activities that provide enjoyment and accomplishment within the individual's current functional capacity. The gradual expansion of activity engagement as rehabilitation progresses creates natural opportunities for mood improvement, while the explicit integration of behavioral activation principles into rehabilitation, goal setting enhances attention to psychological well-being throughout the recovery process. Post-stroke anxiety frequently co-occurs with depression and deserves independent attention in assessment and treatment planning. Anxiety disorders following stroke may manifest as generalized anxiety, specific phobias related to stroke recurrence or falling, or post-traumatic stress symptoms related to the acute stroke experience. The impact of anxiety on rehabilitation participation can be substantial, with fear of falling limiting mobility activities and stroke recurrence fears contributing to activity avoidance and reduced quality of life. Intervention approaches for post-stroke anxiety parallel those for depression, with cognitive behavioral techniques, relaxation training, and graduated exposure demonstrating utility for anxiety management in stroke populations. Aphasia, the acquired language disorder resulting from brain damage to language-dominant hemisphere regions, affects all modalities of language including speaking, understanding, reading, and writing, with profound impacts on communication, relationships, employment, and quality of life. Reviews examining how stroke guidelines inform aphasia assessment and management provide a framework for understanding current evidence-based practice in aphasia rehabilitation. Key recommendations emphasize the importance of early and ongoing speech-language pathology assessment, intensive language therapy during periods of heightened neuroplastic potential, and the integration of communication partner training and environmental modifications to support functional communication beyond the gains achievable through impairment-focused therapy alone. The heterogeneity of aphasia presentations, ranging from predominantly expressive difficulties with relatively preserved comprehension to severe global aphasia affecting all language modalities, necessitates individualized assessment and treatment planning that addresses each patient's specific pattern of strengths and limitations. Comprehensive aphasia assessment characterizes performance across speaking, auditory comprehension, reading, and writing domains, while also evaluating the pragmatic communication abilities that enable functional interaction despite linguistic impairment. Assessment findings guide intervention selection, determining whether treatment should prioritize restoration of specific linguistic functions, compensation through alternative communication strategies, or a combination approach addressing multiple goals. The evidence base for aphasia rehabilitation supports intensive task-specific language therapy as the foundation of effective intervention, with research demonstrating dose-response relationships indicating that greater amounts of therapy produce better outcomes. Constraint-induced language therapy, analogous to constraint-induced movement therapy for motor rehabilitation, combines intensive language practice with constraints on compensatory nonverbal communication to encourage use and strengthening of impaired language systems. Script training approaches focus on functional communication in specific contexts, with repeated practice of conversational routines enabling more fluent communication in trained situations. Semantic feature analysis and phonological component analysis target word-finding difficulties through systematic cueing approaches that strengthen the semantic and phonological networks supporting word retrieval. Communication partner training represents an essential complement to patient-focused therapy, equipping family members, caregivers, and others in the patient's environment with strategies to support successful communication interactions. Partner training addresses conversational techniques such as yes-no question use, reduction of communication demands, allowing adequate response time, and verification of message understanding, while also addressing environmental modifications that reduce communication barriers. The supported conversation for adults with aphasia approach provides a structured framework for partner training that has demonstrated effectiveness in improving both partner communication behaviors and communication success in interactions with aphasic individuals. Augmentative and alternative communication systems, ranging from simple communication boards to sophisticated speech-generating devices, provide important tools for individuals whose aphasia severity limits functional verbal communication. The appropriate role of augmentative and alternative communication in aphasia rehabilitation has evolved from historical concerns about potential interference with language recovery to current understanding that these tools support functional communication and social participation without impeding language therapy progress. Technology advances, including smartphone and tablet applications, have expanded the accessibility and acceptability of augmentative and alternative communication tools, while text-to-speech and speech-to-text applications offer additional supports for individuals with specific patterns of language impairment. The long-term nature of aphasia recovery requires attention to chronic phase communication needs, as many individuals with aphasia continue to experience significant communication limitations years after stroke, despite intensive early intervention. Community-based aphasia programs, communication groups, and peer support networks provide ongoing opportunities for communication practice and social connection that support quality of life in the chronic phase. The psychological impact of aphasia, including high rates of depression, social isolation, and reduced life participation, underscores the importance of addressing emotional well-being alongside communication, rehabilitation throughout the recovery trajectory. The integration of cognitive, psychological, and communication assessment and intervention within comprehensive stroke rehabilitation requires systematic screening protocols, interdisciplinary collaboration, and care planning processes that address the connections among these domains. Screening should occur at rehabilitation admission with repeat assessment at key transition points and whenever clinical concerns arise, using validated instruments appropriate for stroke populations and adapted as needed for patients with communication or cognitive impairments. Positive screening results should trigger comprehensive evaluation by relevant specialists, with findings communicated across the interdisciplinary team to inform rehabilitation planning. Care planning should address the bidirectional relationships among cognitive, psychological, and communication domains, recognizing that interventions in one area may influence outcomes in others. Depression treatment may improve cognitive performance and rehabilitation participation. Cognitive rehabilitation may enhance coping capacity and reduce depression. Communication improvements may enable more effective expression of emotional needs and better social support access. The coordination of specialist interventions with motor and functional rehabilitation ensures that cognitive, psychological, and communication needs are addressed as integrated components of comprehensive stroke recovery, rather than isolated treatment targets. The impact of cognitive, psychological, and communication impairments extends beyond the stroke survivor to profoundly affect family members and caregivers who must adapt to changes in their loved one's personality, abilities, and communication capacity. Caregiver burden associated with post-stroke cognitive and behavioral changes often exceeds that associated with physical disability alone, as caregivers struggle to manage behavioral symptoms, navigate communication barriers, and cope with the psychological changes that alter the fundamental nature of their relationship with the stroke survivor. Comprehensive stroke rehabilitation must address caregiver needs as an integral component of care, providing education, skills training, and emotional support that enable sustainable caregiving while protecting caregiver well-being. Education for family members should address the nature of cognitive, psychological, and communication impairments, including their neurological basis, expected course, and strategies for management and support. Understanding that behavioral changes result from brain injury rather than deliberate choice helps families maintain compassion and patience while managing challenging symptoms. Skills training for communication partners, behavioral management techniques for cognitive and behavioral symptoms, and strategies for supporting the stroke survivor's emotional well-being equip families with practical tools for daily caregiving challenges. Connection to support groups and community resources provides ongoing peer support and access to assistance that reduces caregiver isolation and burden. With this understanding of cognitive, psychological, and communication factors in stroke rehabilitation, let us now address the implementation barriers and health equity challenges that limit our ability to translate evidence into practice for all patients. Despite substantial advances in stroke rehabilitation science and the development of comprehensive clinical practice guidelines, significant gaps persist between evidence-based recommendations and routine clinical practice. These implementation barriers operate at multiple levels, from individual clinician knowledge and skills through organizational factors and healthcare system policies, creating systematic disparities in the quality and accessibility of stroke rehabilitation services. The American Heart Association policy statement on improving access to stroke rehabilitation and recovery identifies these barriers while calling for multi-level interventions to address the gaps between evidence and practice that limit outcomes for stroke survivors. Health equity considerations permeate stroke rehabilitation, with persistent disparities in access, quality, and outcomes affecting racial and ethnic minorities, rural populations, individuals with limited socioeconomic resources, and those facing other structural disadvantages within healthcare systems. These disparities begin with differential stroke incidence and severity patterns across populations and extend through acute care, post-acute rehabilitation, and community reintegration phases, creating cumulative disadvantages that compound over the recovery trajectory. Addressing these disparities requires explicit attention to equity as a quality dimension, with deliberate strategies to identify and remediate the systematic barriers that limit rehabilitation access and outcomes for disadvantaged populations. Implementation barriers to evidence-based stroke rehabilitation operate across multiple levels of the healthcare system, requiring coordinated interventions that address each level to achieve meaningful practice improvement. At the clinician level, barriers include gaps in knowledge regarding current evidence, limited skills in implementing complex interventions, competing demands that reduce time available for evidence-based practice, and attitudes or beliefs that conflict with guideline recommendations. Professional development programs, clinical decision support tools, and practice feedback mechanisms can address clinician-level barriers, though sustained change requires organizational support and system-level enablers. Organizational barriers include inadequate staffing levels, limited access to specialized equipment and technologies, absence of stroke-specific protocols and order sets, and organizational cultures that do not prioritize evidence-based practice or continuous quality improvement. The National Landscape Survey cited in the AHA rehabilitation standards found that 78% of post-acute care sites lacked stroke program oversight structures, 70% lacked stroke rehabilitation leadership, and 66% lacked policies requiring staff stroke education, highlighting the infrastructure gaps that limit implementation capacity across rehabilitation settings. Addressing these organizational barriers requires administrative commitment, resource investment, and systematic quality improvement processes that embed evidence-based practices into routine operations. System-level barriers encompass payment policies that inadequately reimburse evidence-based rehabilitation services, regulatory requirements that impede care delivery, workforce shortages that limit service availability, and geographic maldistribution of rehabilitation resources that creates access barriers for populations distant from specialized centers. Prior authorization requirements for inpatient rehabilitation admission delay care transitions and create administrative burdens that consume clinician time better devoted to patient care. Coverage limitations on therapy services, particularly for chronic stroke survivors, restrict access to ongoing rehabilitation, despite evidence supporting benefits of continued intervention for patients with persistent deficits and rehabilitation potential. Policy recommendations call for development of performance measures aligned with stroke rehabilitation guidelines that would enable monitoring of care quality, identification of disparities, and accountability for equitable service delivery. Value-based payment models that align financial incentives with rehabilitation outcomes could accelerate implementation of evidence-based practices, though careful attention to unintended consequences is necessary to prevent gaming behaviors or discrimination against patients with complex needs who may be perceived as poor risks for outcome-based payment systems. Advocacy efforts by professional organizations and patient groups can influence policy development, building the political will for systemic reforms that address structural barriers to rehabilitation, access, and quality. Racial and ethnic disparities in stroke rehabilitation access and outcomes represent a persistent challenge that reflects broader patterns of healthcare inequity in the United States and other countries. Studies examining racial and rural disparities in stroke discharge disposition have found significant differences in post-acute care placement patterns across racial groups, with Black and Hispanic patients experiencing reduced access to certain discharge destinations compared to white patients even after controlling for clinical characteristics. These disparities may reflect differences in insurance coverage, geographic access to rehabilitation facilities, implicit bias in clinical decision-making, and cultural or language barriers that affect care navigation and advocacy. Rural populations face particular challenges in accessing stroke rehabilitation services due to the concentration of specialized rehabilitation facilities in urban areas and the limited availability of rehabilitation therapists in rural communities. Transportation barriers compound geographic distance, as many rural stroke survivors lack reliable transportation to access outpatient rehabilitation services that may be located many miles from their homes. Telerehabilitation offers promise for addressing rural access barriers, though technology infrastructure limitations, digital literacy challenges, and the need for appropriate patient selection present implementation challenges that must be addressed to realize this potential. Addressing health disparities in stroke rehabilitation requires deliberate, multi-level strategies that target the root causes of inequitable access and outcomes. At the clinical level, implicit bias training, cultural competency education, and structured clinical decision-making tools can reduce the influence of bias on rehabilitation referral and intensity decisions. Language services, health literacy-appropriate education materials, and community health worker programs can address communication and navigation barriers that limit engagement with rehabilitation services among immigrant and limited English proficiency populations. Organizational strategies include routine collection and monitoring of data on rehabilitation access and outcomes stratified by race, ethnicity, geography, and socioeconomic status, enabling identification of disparities and evaluation of improvement efforts. Community partnerships with organizations serving disadvantaged populations can improve outreach, reduce barriers to engagement, and build trust that facilitates healthcare utilization. Investment in telehealth infrastructure and digital inclusion initiatives addresses technology barriers that might otherwise limit the equity benefits of telerehabilitation approaches. Systematic quality improvement approaches provide the methodology for translating evidence into practice and reducing disparities in stroke rehabilitation. The Plan, Do, Study, Act cycle and similar improvement frameworks enable iterative testing of practice changes, with data collection and analysis informing refinements until desired outcomes are achieved. Learning collaboratives bring together teams from multiple organizations to share experiences, learn improvement techniques, and accelerate the spread of effective practices across settings. Learning collaboratives have demonstrated that most participating sites can meet proposed quality standards with adequate support and resources, suggesting feasibility of systematic improvement when implementation supports are available. Program development for stroke rehabilitation should incorporate explicit attention to implementation factors from the outset, designing services that can be delivered reliably within available resources while achieving fidelity to evidence-based principles. Stakeholder engagement in program design, including patients, families, frontline clinicians, and administrators, builds buy-in while ensuring that practical considerations inform service models. Pilot testing enables identification and resolution of implementation challenges before full-scale rollout, while ongoing monitoring supports continuous refinement as experience accumulates. The development of stroke rehabilitation programs within organizations currently lacking specialized services requires assessment of readiness, identification of champions, resource planning, and phased implementation that builds capability incrementally. Systematic outcome measurement using standardized assessment tools enables tracking of rehabilitation effectiveness, identification of patients requiring modified approaches, and comparison of outcomes across settings and populations that supports quality improvement and equity monitoring. Core outcome sets for stroke rehabilitation provide guidance on essential measures that should be collected routinely, including functional independence, mobility, upper extremity function, communication, cognition, and quality of life domains. The timing of outcome assessment should align with clinical milestones and transition points, with assessment at rehabilitation admission, discharge, and follow-up intervals enabling characterization of recovery trajectories and long-term maintenance of gains. Follow-up protocols should extend beyond the intensive rehabilitation period to support ongoing recovery and secondary prevention through the chronic phase. Recommended follow-up intervals typically include assessment at 3, 6, and 12 months post-stroke, with ongoing annual monitoring for patients at risk for late complications or decline. Follow-up should assess not only functional outcomes but also psychological well-being, community participation, caregiver burden, and secondary prevention adherence, enabling comprehensive evaluation of stroke recovery and identification of emerging needs requiring intervention. The integration of outcome data into electronic health records and quality registries supports both individual patient care and population-level quality improvement efforts. Now that we have explored the implementation and equity challenges facing stroke rehabilitation, let us bring together all of the concepts from this course through integrative case studies that illustrate clinical reasoning and practice. The following case studies provide opportunities to apply and integrate concepts from all of the preceding modules in realistic clinical scenarios that reflect the complexity of stroke rehabilitation decision-making. Each case presents a unique patient with distinct clinical characteristics, social circumstances, and rehabilitation challenges, requiring synthesis of knowledge regarding phase-specific protocols, setting selection, exercise interventions, emerging technologies, cognitive and psychological management, and implementation considerations. These cases are designed to illustrate the clinical reasoning process that guides rehabilitation planning across the continuum of care, from acute hospitalization through community reintegration. As we work through each case, consider how the patient's stroke characteristics, medical history, functional status, cognitive and psychological factors, and social circumstances interact to shape rehabilitation planning decisions. Reflect on the evidence base supporting different intervention options and the factors that might lead to different choices for different patients. The discussion sections following each case highlight key decision points and the clinical reasoning underlying recommended approaches, though you should recognize that alternative approaches might be equally valid, depending on local resources, patient preferences, and evolving clinical circumstances. Our first case study involves an acute ischemic stroke with successful recanalization. The patient is Margaret Chen, a 58-year-old right-handed woman who presents with acute onset left-sided weakness and slurred speech. The onset was witnessed at 9:15 a.m. while she was teaching her high school mathematics class, and she arrived at the emergency department at 10:05 a.m., which was 50 minutes from symptom onset. Mrs. Chen's medical history includes hypertension diagnosed 8 years ago, currently managed with lisinopril 20 mg daily, and hyperlipidemia treated with atorvastatin 40 mg daily. She has no history of diabetes, atrial fibrillation, or prior cerebrovascular events. She is a never smoker with occasional social alcohol consumption. Her family history is significant for her father experiencing a stroke at age 72. Mrs. Chen works full-time as a high school mathematics teacher, lives with her husband in a 2-story home with bedrooms upstairs, and is the primary driver in the household. She enjoys gardening, reading, and weekly mahjong games with friends. Her functional baseline was fully independent in all activities with no mobility limitations. Her initial neurological examination revealed moderate left hemiparesis affecting face, arm, and leg, with Medical Research Council grade 3 out of 5 in the upper extremity and 4- out of 5 in the lower extremity. She also demonstrated mild dysarthria and left hemispatial inattention. Her National Institutes of Health stroke scale score was 9. Non-contrast head CT showed no hemorrhage or early ischemic changes. CT angiography demonstrated complete occlusion of the right middle cerebral artery, M1 segment with good collateral circulation. CT perfusion imaging showed a large penumbral region with small ischemic core volume of approximately 15 milliliters, which was favorable for intervention. Mrs. Chen received intravenous alteplase at 10:48 a.m., which was 93 minutes from onset, followed by mechanical thrombectomy, achieving complete recanalization at 12:15 p.m. Post-procedure, her NIHSS improved to 4, with residual mild left facial droop, mild left arm weakness at 4 out of 5, and minimal inattention. She was admitted to the neurological intensive care unit for 24-hour post-thrombolysis monitoring, with blood pressure parameters maintained below 180 over 105 millimeters of mercury. Follow-up MRI at 24 hours showed a small right frontal infarct of approximately 25 milliliters, with no hemorrhagic transformation. The rehabilitation assessment on hospital day 2 found Mrs. Chen alert and oriented with good attention to evaluation tasks, despite mild residual left neglect. Motor examination showed left upper extremity strength of 4 out of 5 throughout with mild coordination deficits, and left lower extremity strength of 4+ out of 5 with normal coordination. Sensation was intact to light touch and proprioception bilaterally. She required minimal assistance for bed mobility and transfers, and supervision for ambulation with a single-point cane due to mild left leg weakness and subtle balance impairment. Her functional ambulation category was 4, indicating independence on level surfaces with supervision. Her Berg Balance Scale score was 42 out of 56, indicating moderate fall risk. Occupational therapy evaluation revealed independence in feeding with setup assistance, moderate assistance for upper body dressing due to left arm coordination deficits and neglect affecting garment orientation, and moderate assistance for lower body dressing and bathing. Fine motor testing showed mild left-hand clumsiness affecting writing and small object manipulation. The 9-hole peg test was completed in 38 seconds with the left hand, compared to a normative value of approximately 20 seconds. And 19 seconds with the right hand. Her functional independence measure motor subscale score was 68 out of 91. Speech-language pathology evaluation found mild dysarthria that did not significantly impact intelligibility, normal language function with no aphasia, and mild left neglect evident on line bisection and cancellation tasks. Cognitive screening using the Montreal Cognitive Assessment yielded a score of 24 out of 30, with points lost on visuospatial tasks, specifically clock drawing and cube copy, and attention, specifically serial 7s. Swallowing evaluation revealed no dysphagia, and she was cleared for a regular diet with thin liquids. Psychosocial assessment found Mrs. Chen tearful at times when discussing the stroke's impact on her work and independence, though she demonstrated good insight, appropriate coping strategies, and strong motivation for rehabilitation. Her husband was present and engaged, expressing commitment to supporting her recovery. Patient Health Questionnaire 2 screening was negative for depression with a score of 1 out of 6. The rehabilitation team identified her as an excellent candidate for intensive inpatient rehabilitation based on her moderate functional deficits, high motivation, medical stability, and ability to tolerate intensive therapy. Let us now consider the first clinical decision point. When should mobilization be initiated for Mrs. Chen, and what precautions should be observed? Current evidence supports mobilization beginning 24 to 48 hours post-stroke for hemodynamically stable ischemic stroke patients. Although Mrs. Chen received thrombolysis and thrombectomy, successful recanalization with minimal residual infarct and no hemorrhagic transformation supports early mobilization within this window. The post-thrombolysis blood pressure parameters should be observed during initial mobilization sessions, with activity held if systolic blood pressure exceeds 180 millimeters of mercury or diastolic exceeds 105 millimeters of mercury. Given her relatively mild deficits and rapid neurological improvement, out-of-bed activity was appropriately initiated on hospital day 2. Approximately 38 hours post-onset, with monitoring for orthostatic hypotension and neurological changes during initial sessions. The second clinical decision point involves rehabilitation setting selection. What is the most appropriate post-acute rehabilitation setting for Mrs. Chen? She demonstrates moderate functional deficits with a functional independence measure motor score of 68 out of 91, with clear rehabilitation potential and excellent motivation. She can tolerate and actively participate in intensive therapy. Her deficits affect multiple domains, including mobility, self-care, and attention with neglect, requiring coordinated interdisciplinary intervention. These characteristics indicate that an inpatient rehabilitation facility is the optimal setting. While her deficits are not severe, the complexity of her presentation, the need for intensive therapy during the critical early subacute window, and her goal of returning to full-time employment support inpatient rehabilitation facility admission. Her husband's availability to participate in education and training further supports this plan. Anticipated inpatient rehabilitation facility length of stay is 10 to 14 days based on her deficit severity and expected recovery trajectory. Mrs. Chen was admitted to the inpatient rehabilitation facility on hospital day 4. Her rehabilitation program included 3 hours of therapy daily distributed across physical therapy, occupational therapy, and speech-language pathology with cognitive therapy services. Physical therapy focused on progressive gait training advancing from single-point cane to supervised independent ambulation, balance training incorporating dual-task activities to address her attentional limitations, and lower extremity strengthening using task-specific functional activities. High-intensity interval training on the recumbent stepper was introduced during week 2 to address cardiovascular deconditioning and potentially enhance neuroplasticity. Occupational therapy emphasized upper extremity task-specific training targeting fine motor coordination, visual scanning strategies for left neglect management, and progressive independence in self-care activities. Virtual reality-based training using a commercially available system was incorporated to provide engaging, high-repetition upper extremity practice, addressing both motor and visuospatial goals. Constraint-induced movement therapy principles were applied through structured practice, emphasizing left arm use during functional activities, though formal constraint was not employed given her relatively mild motor impairment. Speech-language pathology provided cognitive rehabilitation targeting attention and visuospatial processing, with computer-based attention training and paper and pencil visual scanning exercises. Compensatory strategies, including systematic left-to-right scanning and environmental organization, were taught and practiced across therapy settings and nursing care activities. By discharge, her neglect had largely resolved on formal testing, though she continued to benefit from cueing in novel or complex situations. At inpatient rehabilitation discharge on day 12, Mrs. Chen demonstrated significant functional improvement. She ambulated independently without assistive device on level surfaces with supervision for stairs due to her 2-story home, with gait speed improved to 1.1 meters per second, which exceeds the community ambulation threshold. Her Berg balance scale improved to 52 out of 56, indicating low fall risk. Upper extremity function showed substantial gains, with 9-hole peg test improved to 24 seconds with the left hand. She was independent in all basic self-care activities. Her Montreal cognitive assessment improved to 27 out of 30, with continued mild visuospatial inefficiency. Her functional independence measure motor subscale improved to 85 out of 91. The Patient Health Questionnaire 9, completed at discharge, showed no significant depressive symptoms, with a score of 4 out of 27. The third clinical decision point addresses discharge planning. What services and follow-up should be arranged at discharge? Mrs. Chen has achieved functional independence appropriate for discharge home with her husband. Given her continued mild upper extremity coordination deficits and goal of returning to teaching, which requires writing, computer use, and sustained cognitive demands, outpatient occupational therapy 2 to 3 times weekly for 4 to 6 weeks is indicated to continue upper extremity, fine motor training, and ensure readiness for work demands. A home exercise program emphasizing aerobic conditioning through stationary cycling or walking and balance maintenance should be established. Follow-up assessments should be scheduled at 3 months for comprehensive functional and cognitive reassessment, depression screening, and return-to-work evaluation, and at 6 months for secondary prevention adherence, community participation, and quality of life assessment. Driving evaluation is indicated before return to driving given her history of left neglect, even though formal testing has normalized. Mrs. Chen's outcome was excellent. She returned to teaching half-time at 8 weeks post-stroke and full-time at 12 weeks. At 6-month follow-up, she reported full independence in all activities, had resumed driving after passing a comprehensive driving evaluation, and had returned to her gardening and social activities, including weekly mahjong. She remained adherent to secondary prevention medications with well-controlled blood pressure and lipids. Her stroke impact scale showed minimal residual impact with highest scores across all domains. This case illustrates the favorable recovery trajectory possible with successful acute intervention, appropriate rehabilitation setting selection, and intensive evidence-based rehabilitation during the critical early subacute period. Our second case study involves hemorrhagic stroke with aphasia and depression. The patient is Robert Williams, a 67-year-old right-handed man who was found by his wife with right-sided weakness and inability to speak. The onset is unknown. He was last seen normal at 11 p.m. and was found at 6:30 a.m. He arrived at the emergency department at 7:15 a.m. Mr. has a history of poorly controlled hypertension with documented blood pressures frequently exceeding 160 over 100 millimeters of mercury despite prescribed medications of amlodipine, 10 milligrams, and hydrochlorothiazide, 25 milligrams, which he acknowledges taking inconsistently. Additional history includes type 2 diabetes mellitus, managed with metformin 1,000 milligrams twice daily with the most recent hemoglobin A1C of 7.8%, obesity with a body mass index of 34, and obstructive sleep apnea, for which he was prescribed but does not use CPAP therapy. He is a retired automotive plant supervisor who worked in manufacturing for 35 years. He lives with his wife in a single-story home in a rural community approximately 45 miles from the nearest comprehensive stroke center. He has 2 adult children living in other states. His functional baseline was independent in all activities, though he reported reduced activity level and declining mobility over the past 2 years attributed to knee osteoarthritis. Initial examination at the rural community hospital revealed severe global aphasia with no meaningful verbal output and severely impaired comprehension, dense right hemiplegia with 0 out of 5 in the upper extremity and 1 out of 5 in the lower extremity, right facial droop, and rightward gaze preference. His NIHSS was 21. Emergent non-contrast head CT demonstrated a large left basal ganglia hemorrhage measuring approximately 45 milliliters with extension into the left lateral ventricle and early hydrocephalus. Blood pressure on arrival was 218 over 124 millimeters of mercury. The patient was intubated for airway protection and transferred to a comprehensive stroke center where he was admitted to the neurological intensive care unit. Intensive care unit management focused on blood pressure control with a target systolic of 140 to 160 millimeters of mercury, intracranial pressure management, and close neurological monitoring. An external ventricular drain was placed for management of hydrocephalus with elevated opening pressure. The patient remained intubated for 5 days, successfully extubating on day 6 with adequate airway protection despite ongoing severe dysphagia requiring MPO status and nasogastric tube feeding. Repeat CT on day 7 showed stable hematoma with resolving perilesional edema and improved hydrocephalus, allowing external ventricular drain removal. Following medical stabilization, comprehensive rehabilitation assessment was completed on hospital day 10. Physical therapy found severe right hemiplegia with flaccid upper extremity at 0 out of 5 and minimal lower extremity movement with trace hip flexion and no knee or ankle movement. The patient required maximum assistance of 2 persons for all mobility, including bed mobility and transfers. He could not participate in supported standing due to profound weakness and impaired motor control. Sensation was difficult to assess reliably due to aphasia, though withdrawal responses suggested intact pain sensation. Occupational therapy evaluation found him dependent in all self-care activities, requiring total assistance for feeding via nasogastric tube, bathing, dressing, and toileting. The right upper extremity was flaccid without voluntary movement. The left upper extremity showed functional strength and coordination, though he had difficulty following multi-step commands for assessment tasks due to aphasia. He demonstrated appropriate use of common objects such as a spoon and comb when placed in his left hand, suggesting relatively preserved praxis for familiar tasks. Speech-language pathology assessment confirmed severe global aphasia with severely impaired auditory comprehension. Following one-step commands with gestural cues approximately 50% of the time, no reliable yes/no response, and no functional verbal output beyond occasional phonemic approximations. Reading and writing were not accessible. The Western Aphasia Battery. Aphasia quotient was estimated at 12 out of 100, indicating very severe aphasia. Swallowing evaluation showed severe oropharyngeal dysphagia with aspiration on all consistencies, necessitating continued non-oral feeding. Cognitive assessment beyond language was limited by aphasia, though he demonstrated appropriate attention to his environment, emotional responsiveness as evidenced by being tearful when his wife visited and frustrated during therapy attempts, and some evidence of preserved recognition in procedural learning. Depression screening using the Stroke-Aphasic Depression Questionnaire, completed through proxy report from his wife, suggested moderate depressive symptoms requiring monitoring. A family meeting was held to discuss prognosis, rehabilitation goals, and the expected prolonged recovery course, with emphasis that hemorrhagic stroke often has better long-term outcomes than initial severity might suggest. The first clinical decision point for this case involves rehabilitation setting. Is Mr. an appropriate candidate for inpatient rehabilitation, and what factors should guide setting selection? This presents a challenging disposition decision. Mr. has severe deficits limiting his ability to participate in 3 hours of daily therapy, but he demonstrates attention, emotional responsiveness, and motivation suggesting rehabilitation potential. Hemorrhagic stroke patients often show better recovery than initial severity predicts as hematoma and edema resolve. However, his severe aphasia limits communication during therapy, and his dependent mobility status presents safety challenges. 2 reasonable options exist. The first is skilled nursing facility with rehabilitation services initially, transitioning to an inpatient rehabilitation facility if he demonstrates improved therapy tolerance. The second is inpatient rehabilitation facility admission with a modified therapy program, emphasizing shorter, more frequent sessions, family training, and acceptance that he may not meet typical intensity standards initially, but can progress as medical stability and tolerance improve. Given his age, prior independence, and the importance of intensive early intervention, inpatient rehabilitation facility admission was pursued with documented rationale and a modified therapy plan. Mr. was admitted to the inpatient rehabilitation facility on hospital day 14 with a modified therapy program. Initial therapy sessions were limited to 30 to 45 minutes each due to fatigue, with rest breaks and afternoon naps accommodated in the schedule. Physical therapy emphasized bed mobility training, transfer training with progression from maximum to moderate assistance using a sliding board, and supported sitting activities to build trunk control and sitting balance as precursors to standing. Weight-bearing activities through a standing frame were introduced in week 2 as tolerance improved, with bodyweight support treadmill training initiated in week 3 to provide high-repetition stepping practice despite profound weakness. Occupational therapy focused on left-handed self-care training, right upper extremity range of motion and positioning to prevent contracture and shoulder complications, and functional cognitive activities adapted for his communication limitations. Electrical stimulation was applied to right wrist and finger extensors to maintain range of motion and provide sensory input. Simple choice-making and sequencing tasks were incorporated using object manipulation rather than verbal response. His wife participated extensively in therapy sessions, learning transfer techniques, positioning protocols, and strategies for communicating with him despite his aphasia. Speech-language pathology provided intensive aphasia therapy using multimodal approaches including gesture training, drawing, and augmentative communication strategies. A simple communication board with pictures representing basic needs was introduced and practiced with both staff and family. Swallowing therapy included oral motor exercises and systematic trials of modified diet textures, achieving advancement to pureed foods with nectar-thick liquids by week 3, allowing nasogastric tube removal. During week 2, nursing staff reported increased withdrawal, refusal of therapy sessions, and episodes of crying during care. The stroke aphasic depression questionnaire was repeated, showing worsening scores. Given his inability to participate in traditional psychotherapy due to aphasia, a multimodal depression management approach was implemented, including antidepressant medication with sertraline 50 mg daily, increased family presence and engagement, music therapy using songs from his era, and behavioral activation through participation in group activities adapted to his communication level. Photographs of his family and home were incorporated into therapy activities to maintain connection to his identity and goals. By inpatient rehabilitation facility discharge after a 28-day stay, Mr. had made meaningful functional gains despite persistent severe deficits. He transferred with moderate assistance of one person using a sliding board, achieved supported standing for 5 minutes with moderate assistance, and had early emergence of right lower extremity movement with 2 out of 5 hip flexion and 1 out of 5 knee extension. His right upper extremity remained flaccid. He required moderate assistance for most self-care activities, completed with his left hand. Aphasia remained severe, though he demonstrated improved auditory comprehension, following one-step commands reliably and two-step commands with cues approximately 60% of the time, and emerging use of the communication board for basic needs. Depression symptoms improved with continued medication and behavioral interventions. He advanced to a mechanical soft diet with nectar-thick liquids with supervision. The second clinical decision point addresses discharge setting and services. What discharge setting and services are appropriate given his ongoing care needs and rural residence? Mr. continues to require substantial assistance with all activities, and his wife will be the primary caregiver. Assessment of her capability and willingness to provide this level of care is essential. Their rural location, 45 miles from specialized rehabilitation services, presents significant barriers to outpatient therapy access. Discharge home with home health services is appropriate if his wife can manage his care with training and support. Home health physical therapy, occupational therapy, and speech-language pathology should be arranged for the maximum available frequency, typically 2 to 3 visits per week for each discipline. Telerehabilitation for speech-language pathology should be explored to supplement in-person visits and enable access to aphasia-specialized treatment not available locally. Respite care resources and caregiver support services must be arranged to prevent caregiver burnout. A hospital bed, wheelchair, bedside commode, and transfer equipment are essential home modifications. At 6-month follow-up, Mr. continued to demonstrate gradual recovery. He ambulated with a quad cane and ankle-foot orthosis with contact guard assistance for household distances. His right upper extremity showed emerging proximal movement with 2 out of 5 at the shoulder and 2 out of 5 at the elbow, though his hand remained non-functional. He was modified independent in feeding with adaptive equipment and required minimal to moderate assistance for other self-care. Aphasia improved to moderate severity with a Western aphasia battery aphasia quotient of 48, with functional communication using a combination of single words, gestures, and communication device for complex messages. He participated in a community aphasia group via telehealth monthly, providing peer support and ongoing language stimulation. Depression remained managed on sertraline with stable mood. His wife reported manageable caregiver burden with use of an adult day program, 2 days weekly, providing respite. This case illustrates the extended recovery timeline for severe hemorrhagic stroke, the importance of addressing depression and aphasia, the value of telerehabilitation for rural access, and the need for comprehensive caregiver support. This concludes our comprehensive course on stroke rehabilitation. We have covered the critical concepts of phase-specific rehabilitation protocols for ischemic and hemorrhagic stroke, the factors guiding rehabilitation setting selection across the care continuum, the evidence base for exercise interventions including task-specific training, aerobic exercise, resistance training, and balance rehabilitation, the emerging technologies including robotics, virtual reality, and neuromodulation that are expanding our therapeutic toolkit, the assessment and management of cognitive impairment, depression, and aphasia, and the implementation barriers and health equity challenges we must address to ensure all stroke survivors receive evidence-based care. The case studies have illustrated how these concepts integrate in clinical practice, demonstrating that optimal stroke rehabilitation requires both scientific knowledge and skilled clinical judgment applied to the unique circumstances of each patient. As you return to your clinical practice, I encourage you to apply the principles and evidence we have discussed to continue developing your skills in stroke rehabilitation, and to advocate for the resources and policies needed to ensure equitable access to high-quality rehabilitation services for all stroke survivors. Thank you for your commitment to advancing stroke rehabilitation practice, and I wish you the best in your continued professional development in this important field. We will now review the exam questions to solidify your understanding of the key concepts covered in this course on stroke rehabilitation. Question 1. According to current evidence, when should mobilization be initiated for hemodynamically stable ischemic stroke patients? The correct answer is B, between 24 and 48 hours post-stroke onset. Rationale: the timing of early mobilization has been refined significantly based on landmark trial data. The AVERT trial demonstrated that very early mobilization, meaning within the first 24 hours, was associated with reduced odds of favorable outcomes at 3 months. However, prolonged bed rest beyond 48 hours increases complications including deep vein thrombosis, hospital-acquired pneumonia, and pressure injuries. The 24 to 48-hour window represents the optimal balance, allowing adequate time for cerebral perfusion stabilization while initiating activity early enough to prevent immobility-related complications and begin engaging neuroplastic recovery mechanisms. Question 2. Which of the following best describes the therapy intensity requirement for inpatient rehabilitation facilities? The correct answer is C, a minimum of 3 hours of daily multidisciplinary therapy. Rationale: inpatient rehabilitation facilities operate under specific regulatory requirements that distinguish them from other post-acute care settings. The 3-hour daily therapy requirement reflects the intensive service delivery model designed to maximize functional recovery during the critical early weeks following stroke. This multidisciplinary approach typically includes physical therapy, occupational therapy, and speech-language pathology services delivered in a coordinated manner. The intensity requirement is grounded in evidence demonstrating dose-response relationships between therapy intensity and functional outcomes, particularly during the period of heightened neuroplasticity in the subacute phase. Question 3. According to Bayesian network meta-analyses comparing different aerobic exercise interventions, which approach demonstrated the highest-ranked improvement in peak oxygen consumption for stroke survivors? The correct answer is A, high-intensity interval training. Rationale: network meta-analysis methodology allows for indirect comparisons across multiple intervention types, even when head-to-head trials are limited. High-intensity interval training emerged as the top-ranked intervention for improving cardiorespiratory fitness, with mean improvements in peak oxygen consumption of approximately 2.9 milliliters per kilogram per minute compared to usual care. This finding represents a paradigm shift in stroke rehabilitation, as clinicians historically favored conservative, low-intensity approaches due to safety concerns. Current evidence indicates that appropriately supervised high-intensity training is both safe and more effective for improving the cardiovascular deconditioning that frequently accompanies stroke. Question 4. According to the Cochrane Systematic Review on Electromechanical Assisted Gait Training, which patient population derives the greatest benefit from robotic gait training? The correct answer is D, patients who are non-ambulatory within the first 3 months post-stroke. Rationale: the Cochrane Systematic Review represents the highest level of synthesized evidence on robotic gait training effectiveness. While robotic-assisted gait training combined with conventional physiotherapy increased the odds of achieving independent ambulation overall, subgroup analyses revealed that benefits were concentrated among specific patient populations. Non-ambulatory patients within the first 3 months post-stroke showed the strongest treatment effects. This makes clinical sense as these patients require the body weight support and repetitive stepping practice that robotic devices provide, and they are still within the window of enhanced neuroplastic potential. Patients who are already ambulatory or those in the chronic phase showed less pronounced benefits from this resource-intensive intervention. Question 5. According to network meta-analyses examining non-pharmacological interventions for post-stroke depression, which intervention type demonstrated the highest efficacy for reducing depressive symptoms? The correct answer is A. Home-based exercise interventions. Rationale: post-stroke depression affects approximately 1/3 of stroke survivors and significantly impairs rehabilitation outcomes and quality of life. Network meta-analyses comparing various non-pharmacological approaches found that home-based exercise programs demonstrated superior efficacy for reducing depressive symptoms. This finding has important clinical implications. Exercise provides neurobiological benefits including increased brain-derived neurotrophic factor and improved neurotransmitter regulation. The home-based delivery model may enhance efficacy by promoting patient autonomy, reducing barriers to participation, and integrating therapeutic activity into daily routines. This evidence supports prescribing structured home exercise programs as a dual-purpose intervention, addressing both motor recovery and psychological well-being. Question 6. According to National Landscape Survey data on stroke rehabilitation infrastructure, what percentage of post-acute care sites lack stroke program oversight structure? The correct answer is D, 78%. Rationale: national survey data have revealed substantial gaps in stroke rehabilitation infrastructure across post-acute care settings. The finding that 78% of sites lack formal stroke program oversight is particularly concerning because structured programs are associated with improved adherence to evidence-based practices and better patient outcomes. This infrastructure deficit exists alongside related gaps, including the absence of stroke rehabilitation leadership, stroke-specific protocols, and mandatory staff education requirements at the majority of sites. These findings highlight a significant quality improvement opportunity and underscore the need for healthcare systems to invest in developing dedicated stroke rehabilitation programs with appropriate administrative oversight and clinical leadership. Question 7. What is the established minimal clinically important difference for the Fugl-Meyer assessment upper extremity subscale? The correct answer is B, approximately 5.25 points. Rationale: the minimal clinically important difference represents the smallest change in a measurement that patients perceive as beneficial. For the Fugl-Meyer assessment upper extremity subscale, which measures motor impairment on a scale from 0 to 66 points, this threshold has been established at approximately 5.25 points. Understanding this benchmark is essential for clinical decision-making and research interpretation. When a patient demonstrates a change meeting or exceeding this threshold, clinicians can be confident that the improvement represents meaningful functional benefit rather than measurement variability or statistical artifact. This value guides goal setting, treatment planning, and evaluation of intervention effectiveness in both clinical and research contexts. This concludes the exam review for the Stroke Rehabilitation Evidence-Based Update course. These questions have covered essential concepts including optimal mobilization timing, therapy intensity requirements, evidence-based exercise prescription, robotic gait training applications, management of post-stroke depression, healthcare infrastructure considerations, and interpretation of motor recovery assessments. Question 8. The subacute phase of stroke rehabilitation, which represents the period of most intensive rehabilitation intervention, typically spans which time frame post-stroke? The correct answer is C, from approximately 1 week to 3 months post-stroke. Rationale: the subacute phase represents a critical window during which the brain demonstrates maximal neuroplastic potential, and patients can typically tolerate progressive increases in therapy intensity and duration. This phase is often subdivided into early subacute, spanning weeks 1 through 4, and late subacute, spanning weeks 5 through 12. Understanding this timeline is essential for rehabilitation planning because it identifies when patients are most likely to benefit from intensive therapeutic intervention. The enhanced neuroplasticity during this period creates optimal conditions for motor learning and functional recovery, making it imperative that patients receive appropriate rehabilitation services during this window. Question 9. According to systematic reviews examining virtual reality for upper extremity rehabilitation, what was the standardized mean difference for motor function improvement as measured by the Fugl-Meyer assessment? The correct answer is C, 0.45. Rationale: meta-analyses of randomized controlled trials have demonstrated that virtual reality interventions produce significant improvements in upper extremity motor function compared to control conditions. The standardized mean difference of 0.45 represents a moderate effect size, indicating clinically meaningful benefits. Virtual reality interventions also showed improvements in range of motion, muscle strength, and independence in daily activities. These findings support incorporating virtual reality technology into upper extremity rehabilitation programs as an adjunct to conventional therapy, particularly given the potential for increased engagement and motivation that immersive technologies can provide. Question 10. What percentage of acute stroke patients are affected by aphasia? The correct answer is B, approximately 30%. Rationale? Aphasia is an acquired language disorder resulting from brain damage to language-dominant hemisphere regions, typically the left hemisphere in right-handed individuals. Affecting approximately 30% of acute stroke patients, aphasia presents profound challenges for communication, social participation, and psychological well-being. The heterogeneity of aphasia presentations, ranging from primarily expressive deficits to primarily receptive impairments to global involvement, necessitates individualized assessment and treatment planning. Speech-language pathologists play a critical role in evaluating aphasia severity and type, developing targeted intervention strategies, and supporting communication partner training to optimize functional communication outcomes. This concludes the exam review for the Stroke Rehabilitation Evidence-Based Update course. These questions have covered essential concepts including optimal mobilization timing, therapy intensity requirements, evidence-based exercise prescription, robotic gait training applications, management of post-stroke depression, healthcare infrastructure considerations, interpretation of motor recovery assessments, rehabilitation phase timelines, virtual reality interventions, and aphasia prevalence and management.